Good morning to all of you. Today I am going to discuss access technique. Access is called key of success. In minimal access surgery, technique of entering into the abdomen with the telescope and instrument is called access technique. As we know that name itself is minimal access surgery, so access is the most important part of the laparoscopy. If you have reached inside the abdomen safely without injuring any bowel and vessel, your 50% of work is already done. Because 50% of the complication in laparoscopy happens at the time of access. Once we enter inside the abdomen, at that time we do the mistakes. So where should I put my port? This is a very common question asked wherever you will start any laparoscopic surgery. This comes in your mind, obviously, and not only for different surgeries, even for the same surgery in different patient. It comes in our mind, where should I put my port? And the statistical data has shown that most common cause of stressful surgery is the wrong port position. So you need correct planning, you have to develop a skill, you should have idea about the target, a strategy of the port position, and then only we can achieve the goal. If your port is wrong, your surgery will take more time and it will become more expensive as well, because you have to use the advanced instrument like a stapler, laser welding and argon beamer, different type of advanced instrument you have to use. The primary port is also called optical port, and that is the first port which you have to introduce, and it is very important for safety point of view. Secondary ports are not important for safety because they are important for ergonomics, because secondary ports will be introduced under vision. But the primary port is the first port which will take your telescope inside the abdomen. So this is very important and we should correctly introduce it. And if you see, there are 6 sides of the optical ports. Supraumbilical, that is above the umbilicus. Then infraumbilical, that is below the umbilicus. Third is superior crease of umbilicus, that is also called crying incision. Fourth is inferior crease of umbilicus, that is called a smiling incision. Fifth is transumbilical, that is on the base of the umbilicus. And the sixth is Palmer's point. These are only 6 sides of the primary port. There is no 7th side for laparoscopy. If you are doing retroperitoneoscopic nephrectomy, then you will put the port over the inferior crease of in between the costal margin and iliac crest. But retroperitoneoscopy is not laparoscopy, it is retroperitoneoscopy. If you are doing TAPE, totally extraperitoneal hernia surgery, then one port in between umbilicus and pubic symphysis, one is supraumbilical, another is below the umbilicus, all the three in the same line. But that is also not laparoscopy, it is extraperitoneal surgery. However, laparoscopy word is so popular that we tell everything laparoscopy. Like you will see, it is written, article published, laparoscopic TAPE. Technically it is wrong. You will be surprised, some of the article published in authenticated journal, laparoscopic thyroidectomy. And many a time I am thinking, how come thyroid entered into the abdominal cavity? So they did laparoscopic thyroidectomy. It should be minimally invasive thyroidectomy. But laparoscopy word is so popular that everything is laparoscopy. You will be surprised that one of my friend is orthopedic surgeon, and we were talking, then he was saying that once the patient come for the anterior cruciate ligament repair, he is saying that I want laparoscopy. And then he said that yes, we will do laparoscopy. Because if he will tell I will do arthroscopic, then he will run away, that he is doing something else. I told laparoscopy and he is saying arthroscopy. He doesn't know how to do laparoscopy. So everything is laparoscopy, but technically laparoscopy has only these 6 sites. There is no 7th site possible. Primary port I am talking about. Now, whenever you are performing any upper abdominal surgery, you will use supraumbilical port. Upper abdominal surgery means fundoplication, Hiller's myotomy, hiatus hernia, bariatric surgery. In all, you have to use supraumbilical. Supraumbilical means above the umbilicus. And 80% of the operative gynecological surgery, we use supraumbilical. It is the most popular port position in laparoscopy. 80% of the operative gynecology. Only in diagnostic you are using umbilicus or a small ovarian cyst or ovarian drilling PCOD, tubal patency test, simple fimbrial adhesions, you can use umbilicus. Otherwise, for TLH, for myomectomy, for sacrocolpopexy, you must use supraumbilical. If you will use umbilicus and then you gynae surgery, and your uterus will be pushed by colpotomizer cranial traction, your fundus will touch the telescope. You cannot perform it. You need a panoramic view, so supraumbilical is must. And upper abdominal, supraumbilical is must. Now the question is, supraumbilical is a vague term, that is above the umbilicus. And it may be 2 centimeter above, 5 centimeter above, 10, so how I will decide where to put? The answer is that it should be 18 centimeter below the GP sternum whenever you perform general surgical upper abdominal procedure. You can see here, this is the GP sternum. So this should be 18 centimeter below the GP sternum. Why 18 centimeter below? Because your instrument is 36 centimeter. And if you are doing in morbid obese patient, then it should be 22.5 centimeter below the GP sternum. Because in morbid obese patient, your instrument is 45 centimeter. If you will use less than that, then your elevation angle increases. And if you will use more than that, then your elevation angle decreases. Elevation angle is the angle between the instrument and the body of the patient. So, umbilicus is never considered as a reference point to decide supraumbilical port, because umbilicus is very variable. It is never in the midline, in the middle of the, most of the patient, young patient and nulliparous patient and young man, you will see most of the time umbilicus is in between the GP sternum and upper border of pubic symphysis. But gradually once age increases and multiparous women and obesity, umbilicus descend down. And then if you will use umbilicus to calculate supraumbilical, you will be wrong. You know, umbilicus is so variable that if you will see WWF sumo people, their umbilicus, they have to hang it up like that. See their umbilicus, they are giving a support of this and they have to hang it up. If they don't hang their umbilicus up, it will go below the scrotum. So if you will put here the port, you can never do even the cholecystectomy, appendectomy, nothing you can do. So in those situations, even if patient come for cholecystectomy, you have to use supraumbilical port. Otherwise, if they will sit on the chair, their umbilicus will touch the floor. And it is not only for the upper abdomen, so every patient you have to decide how much above. Now coming for gynae. In the gynae, generally it should be, if the organ is not palpable, if the organ is not palpable, that means it is in pelvis. Like normal uterus you cannot palpate without by manual examination, because there is a halosacral curve. So in the pelvis, if normal uterus, normal ovary, abdominal palpation, you cannot feel it. Then it should be 18 centimeter above the upper border of pubic symphysis. And in obese patient, automatically it will go supraumbilical because their umbilicus is displaced down. And if it is palpable, like you have a large uterus, large fibroid, then it should be 22.5 centimeter above the palpable part. Why 22.5 centimeter above? Because suppose you are performing myomectomy, then your target is not the fundus of the myoma. Suppose this is uterus and here is the myoma, then from this you should go 22.5 centimeter above. Sorry, from this point you should go 22.5 centimeter above. Why? Because your target is here. Your target is not the fundus of the pathology. Target is what? Target is the most crucial part of dissection. Like in appendectomy, our target is not the tip of the appendix, it is base of the appendix. In cholecystectomy, target is not our fundus of the gallbladder, it is the cystic pedicle, Calot's triangle. Because that is the most crucial part, most of the mistake happen there. In nephrectomy, target is the hilum of the kidney, not the upper or lower pole. So from there you have to calculate. And if you cannot palpate, then upper border of pubic symphysis you should use. So it has to vary according to the size of pathology. You know, sometimes if pathology reaches up to the umbilicus, suppose here, that much big fibroid, then you have to put the port almost near the GP sternum here. But the question is that near the GP sternum directly I cannot go blindly, because there is lever, there is the falciform ligament I can enter. So first you have to go Palmer's point, and then under vision you will put the telescope here. And then transfer telescope from here to there, that I will discuss later. So this is about supraumbilical port. Now coming to infraumbilical. Infraumbilical port is most of the time used by the gynecologists for deep pelvic surgery. Like some of the gynecologists, when they do tube ligation camps in India, single puncture sterilization, they use infraumbilical, 3 centimeters below the umbilicus, because they don't use Veress needle, they do direct trocar insertion and then do the single puncture with the laparocator one side and another. Already I have shown you laparocator. So in that they prefer infraumbilical, so there will be no chance of injury to the vena cava or aorta. If you are doing upper abdominal surgery in pediatric patient with adult instrument, you have to use infraumbilical. Suppose there is a 6-year, 8-year-old child and you want to do cholecystectomy and you don't have pediatric instrument, then you have to use infraumbilical, because suppose this is a small child, here is the umbilicus, here is the lever, this is the gallbladder, and if you will go in the, then your telescope will become too near, and if you will try to pull the telescope, telescope will come in the cannula, and as soon as telescope is withdrawn in the cannula, you have a tubular vision, your field of vision become completely narrow. So that's why you have to use infraumbilical port. Infraumbilical is also preferred sometime by some of the urologists for radical prostatectomy, and some people they use for birth suspension, because you can fly over to the bladder and you can enter into a space of radius, retropubic area. But it is less common compared to supraumbilical. Now over the umbilicus there are 3 sides. Altogether 6, so this is 3 sides. One is superior crease of umbilicus, that is called crying incision. Another is transumbilical, that is on the base of umbilicus. This is transumbilicus. And third is inferior crease of umbilicus, that is called a smiling incision. This is a smiling incision. These all 3 are umbilical incision. You know, we should not consider the supraumbilical as superior crease or infraumbilical as inferior crease. These all three ports are over the umbilicus itself. And the sixth is Palmer's point. Palmer's point is the most attractive site of the primary port position wherever umbilicus is diseased. This is Palmer's point. It is the most attractive site of the primary port position wherever umbilicus is diseased. And this point is 2 centimeter below the costal margin. Here is the costal margin and this is the Palmer's point. 2 centimeter below the mid-clavicular line. It is the most attractive site of the primary port position whenever umbilicus is diseased, like you have umbilicus hernia, umbilicus sinus, or any midline incision reaching up to the umbilicus. Then you can neither use infraumbilical nor umbilicus nor supraumbilical, because you have to expect extensive intra-abdominal adhesion, just like you have seen on Saturday in incisional hernia, that if we would have used supraumbilical or infraumbilical, might have entered into a small bowel. Mishra's point is also similar to the Palmer's point, but it is a stretched Palmer point, which we stretch it to bring it down and then we put it. But basically it is a modification of Palmer's point only. Advantage is that if Palmer point is used again before, if you use on the Mishra's point, then over the rib the bowel cannot come to adhere. So adhesion will not there. Another, that after pneumoperitoneum it will remain stretched down, and once you will remove the pneumoperitoneum again it will go over the rib. So you don't need port closure because hernia cannot happen. So but basically it's just a modification. Why Palmer point is better? Because it has 4 advantages. One of the biggest advantages is this is the only part of hollow viscous which can be deflated just by putting a nasogastric tube. Hollow viscous in entire GIT, this is the only part which can I easily deflate it by just putting a nasogastric tube. You cannot deflate the hepatic flexor of colon, you cannot deflate the cecum, you cannot deflate sigmoid, but a stomach you can deflate. And deflated organ is very difficult to rupture, puncture. If you have a inflated balloon in the birthday party, the kids are touching with the toothpick and it get ruptured. But same balloon, if it is collapsed, air is leaked, if they touch, it will not puncture, it move away. So once you have put nasogastric tube and deflated it, after that even your trocar touches or Veress needle touches, there is a retrogastric cushion. Below the stomach there is a huge amount of omental bursa which act as a cushion for stomach. So it dimpled away, it won't perforate because it doesn't give you any counter. Counter is required to puncture. First. Second, that being in the left hypochondrium and because of below the rib is always keeping the anterior abdominal wall lifted up. So there is a potential space. So you don't have to lift the abdominal wall, just you have to pull it down. You don't need to lift it because rib is already lifting it up. Third, the stomach is a good organ to perforate. Why? Because it is used to perforate in the nodes. Natural orifices, transluminal endoscopic surgery. Gynecologists, for their female patient, they always prefer to do nodes by V nodes, vaginally. Urologists also use V nodes. V nodes is very popular, and even transvaginal extraction of kidney is also popular in cases of nephrectomy, very popular. These all are transvaginal extraction of the kidney. It's a for donor kidney also, transvaginal route of kidney extraction. A lot of surgeons, we use it for very huge gallbladder, big gallbladder, any tumor. So transvaginal. But how in the male you will do? In male you will do transgastric. And transgastric surgery is very getting popular. This is transgastric. Transgastric cholecystectomy, transgastric appendectomy. It's a novel procedure. Transgastric, 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 transgastric. You can see all are transgastric. This is transgastric, transgastric, transgastric. So how they do? They put one endoscope and they perforate the anterior wall of the stomach, enter into the abdomen, and gallbladder will come through the mouth. Mouth it will be pulled, and then endoscopically clip is applied. Only titanium clip is applied. There are endoscopic clip which you will apply. So that's why I am saying stomach is a good organ to perforate. Even if you perforate it, next advantage is that it doesn't create any bacterial peritonitis. Stomach is a sterile organ. It doesn't have bacteria, not possible to bacteria to grow in a stomach. Human stomach. In cattle stomach, ruminant animal stomach, there are 4 chambers. That's why they are called ruminating animal. So they first eat in one chamber and they store. After that, once they are resting, they bring it again in the mouth and they chew it. They don't chew at the time of grazing. Once they have grazed it, then they sit quite somewhere, bring again in the mouth and they chew it. And then they again engage it in another chamber. In that chamber, huge amount of bacteria is there. First chamber is acidic. So they kill the bacteria, and second it is again bacteria is loaded for the digestion of cellulose and other. That's why in the animal dissection all over world, pig is used, because pig is monogastric animal, identical to the human. We don't use goat. Only in our UAE center in Dubai we are using goat, because in Muslim countries there is no pig. If you go to Saudi Arabia and United Arab Emirates and Iran, pig is eliminated from entire country. This species itself is eradicated. They have removed the pig from country because it is called haram animal, so you cannot use it. But in USA center and in India we are using pig because it is monogastric, identical to the human. In pig, problem is that their stomach reaches up to the upper border of pubic symphysis, multiple chambers. In the goat, so you cannot use. Monkey is very identical, but it is coming in wild animal. The government will not give you license to use it. So we have only the license by Government of India to use the pig for the experiment and the research. So this is important. And palmar is because human is monogastric, so you can deflate it completely. And if it is perforated also, just take a suture and tie it. You don't need ileostomy, colostomy, nothing. Because stomach is a very good muscular organ. It has one oblique layer of the muscle. And this oblique layer of the muscle helps you to suture nicely. Palmar point is so attractive site of the primary port position that many of the surgeons, they routinely introduce Veress needle and trocar with the palmar in every case. Every case. They make it a routine. But if you are expecting extensive intra-abdominal adhesion, then it is must. Now, in many of the situation, once you done access with the palmar's point, after that, you may not be continue the telescope in the palmar's point. Like suppose you want to do hysterectomy, here the uterus, and there is a midline adhesion. Now you will go with the palmars, and under vision of palmar you will put supraumbilical port, and then transfer telescope from here to there. Because keeping the telescope in the palmars, you may not be able to perform entire hysterectomy. Why? Maybe this side of the uterine artery and pedicle you may see, but other side will be invisible, because your port is in one side. So that's why you cannot continue the entire hysterectomy with comfortable position in the palmar. So purpose of the palmar is just to enter supraumbilical safely. After that, it won't be of any use. Any use. Post-operatively, patient will ask you that, madam, why it is there? You told 3 ports, so 3 port is okay, supraumbilical and these two, but this palmar you have never told. You should tell the patient that I will not charge for it, it is free for you. Because it makes our entry safer. So same is cholecystectomy. Patient has previous laparotomy and keeping the telescope in the palmars, you cannot continue the cholecystectomy comfortably. With the struggling you can do, but not comfortably. So purpose is put the telescope and then have the inferior crease of umbilicus under vision. If adhesion is do adhesiolysis, and trocar should be introduced under vision, and then transfer telescope from here to there. And that's why many people, they routinely use the palmars for entry. However, if you are performing ventral hernia and all, just like you saw incisional hernia, it is a good point for keeping the optical port throughout the surgery. Now, among the superior crease, inferior crease and transumbilical, inferior crease is considered safer for primary port. Inferior crease, safer for primary port. Why? Because it is central location, so better ergonomics because of less swording and easy access. You know, if you have to put one CCTV camera in your dome of the temple or the mosque, where you will like to have? In the center location. Because if you will keep in one corner or another, all the 3 corners will be visible, but the corner where you have put that will be dark. If you have to put one light inside your room, you will try to keep in the center. So ideally, inferior crease is the central of umbilicus, of abdomen, normal abdomen, so it is preferred. If it is normal umbilicus, not the descended down, then of course you will use supraumbilical. Another advantage is it has less hernia. Because all the remnant of the umbilicus is attached over the inferior crease. What are the remnant? You have the medial umbilical ligament, you have the median umbilical ligament, all these remnants are attaching to the inferior crease. And the cell intelligence of this area has a spontaneous capacity of valve action, and due to that umbilical tube and confluence skin, it has a tendency to close spontaneously. Because there is a vitreointestinal tract and we can dilate the obliterated vitreointestinal tract. Do you know this idea of dilating the obliterated vitreointestinal tract was given by a Scandinavian surgeon. So that's why it is called a Scandinavian technique. What is that technique? Dilatation of the obliterated vitreointestinal tract, which was present in the fetal life and got obliterated in the adult. So that's why inferior crease is better, because it has an umbilical tube. However, some people they use transumbilical. Transumbilical is the weakest part of the abdominal wall. And if you go through the transumbilical, your entry will be very easy. Boom, you will enter. But you must use to close the port, because if you will not close the port, you will have high chance of hernia. Inferior crease of umbilicus has one more advantage, that even if you increase the incision and at the end you close it, it will give you, due to the confluence skin of the umbilicus, it will give you a access of 20 centimeter, but diameter will be only 10 centimeter. What is that? I will tell you. See, this surgery is going single incision laparoscopic surgery. This is single incision laparoscopic surgery. And here, this side is inferior crease of umbilicus. And this is ohm shaped incision. Ohm is a unit of resistance. This is ohm shaped incision. And if you see very carefully, why inferior crease? This is inferior crease, this one. And why ohm shaped incision is given? The beauty of this ohm shaped incision is length is 20 mm. This is length and diameter is 10 mm. Diameter is 10 mm because of confluence nature of the skin. So you can hold two Ellis forceps, you can cut superficial and deep fascia, and after that you can try to stretch it, and then you will enter. And once you will enter, you have to extend the rectus. Rectus has to be extended up to 20 mm. Just this is a rectus. You know, in the midline, along the linea alba, we have only one rectus sheath. Either side you have muscle, so two rectus sheath, superior and inferior. But in the midline, you have only one rectus sheath. And this is how you will put it. And once you will put this rectus sheath, after that, you will start performing the surgery. And then you will stretch the rectus sheath, extend the rectus sheath. After that, put the finger, feel all around the adhesion. Then use a small S retractor, and then stretch it. It becomes now 20 mm. This is 20 mm. And then this is a Seals port which you will introduce. Seals port is 20 mm. And in that Seals port, under one port you will put other three ports, 5 mm. And this is how, remember, single incision laparoscopic surgery is not a single port surgery. Port is 3, incision is only single. And this is how you will do. And at the end of, once you will remove this port and close all the layers and skin, scar will be visible. Scar will not be visible. Thanks to umbilicus, due to the confluent nature of the skin of the umbilicus, it has a great capacity to hide the scar. So transumbilical is not good, because transumbilical, if you will give 20 mm, it will go transverse, big scar will be visible. But in the inferior crease, because you will go round and you will make ohm shape, so a scar won't be visible. So even for single incision it is good, because transumbilical is the weakest part of abdominal wall, chances of hernia is more. Inferior crease has vitreointestinal tract. So this is the another advantage. Because of central of gravity, umbilical tube and valve action, less hernia. Another advantage, less infection. Infection is also less compared to transumbilical, less infection. Why infection is less? Because transumbilical area is a dirty area. It's a dirty area. And that area has a disadvantage, that it has a high overload of Streptococcus epidermis bacteria. That's why you might have seen that when you are taking a shower, you are always taking the extra care to clean the umbilicus. With the shampoo or soap, you want to clean the umbilicus. If you will not clean the umbilicus, you will have a lot of infection chances. So this is very important. Because of high load of Streptococcus bacteria, if you will give a transumbilical incision, it creates weeping umbilicus. Weeping umbilicus means for many months, patient has some fluid coming out. Patient will come after 6 months of surgery and patient will say that, madam, whenever everything is fine, but whenever I go to shower and press, some fluid is coming. And it smells very bad. What is this? Because this is called weeping umbilicus. It is weeping, crying with the tears coming out. Because it is the thinnest part of abdominal wall and it has a debris, because it is a warm area and humid area, because of confluent nature of skin. Whereas inferior crease of umbilicus, no bacterial flora and it's a dry surface. No bacterial flora and dry surface. So that's why a smiling incision is better. And if you will give a smiling incision, you will keep on smiling. You will not have increased hernia, you don't have increased infection, and you don't have the problem of healing. That is very important. And that idea was given by a Scandinavian surgeon. So that's why it is called a Scandinavian technique. What is a Scandinavian technique? that you can dilate the obliterated vitreointestinal tract which is attached with the inferior crease of umbilicus. All the remnant of the fetal remnant of the umbilical artery, that is the medial umbilical ligament, and urachus, that is median umbilical ligament, all is attached, vitreointestinal tract, all is attached with the inferior crease of umbilicus. Now, let us start the axis. First, what you should do, you should check the spring action of the Veress needle. So, as we have discussed, you should do like that, because if a spring is not working, it is risky. So, this is a spring. It is click sound should come. If you do like that and if you feel it's not going in, then it is extremely risky. You should not use it. If you are using disposable, then you should take in your hand and you should check the color. Already I have shown you during Veress needle that this is changing the color, green and red. Once you press it, it becomes red. Once you leave it, it becomes green. So that way you can check that my Veress needle is working. After that, take a syringe and inject the syringe and do the patency test. So these two tests is done. After that, you will use two Ellis forceps to invert the crease of umbilicus. Purpose of Ellis forceps is just to invert the crease of umbilicus. After that, with 11 number of knife, you will stab the inferior crease of umbilicus. Don't use 15 number of knife. If you use 15 number of knife throughout the axis entry, sorry, your gas will leak, and then you can have the wrong quadromanometric indicator. This is 11 number knife. This is sharp. This is 11. And you need to give just 1 mm stab gun. Many people in the beginning itself they give 11 mm because they think the trocar के लिए तो फिर डालना है पहले ही बढ़ा लो. This is not good. Because initially only if you give 11 mm, then half of the gas will keep on leaking outside. Throughout the quadromanometric indicator, they don't read. They don't have any idea what is quadromanometric. They only keep on palpating that, हाँ, पेट भर गया, अब चलो trocar डालो. This is not good. So only a stab 1 mm with 11 number of knife. 15 mm if you will use the knife, then it will give, this is 15 mm. Then you cannot stab, you have to cut. Because it is round, it is used for open surgery, not for laparoscopic stabbing. So you stab it. After that, you will hold the Veress needle like a dart. And where to hold the Veress needle, already I told you that should be held 4 plus thickness of abdominal wall. 4 plus. Why you will say, why 4 centimeter extra you are taking? So this is the abdominal wall is, suppose you will press it and it is 4 centimeter, then I have to keep 8 centimeter naked. And if suppose abdominal wall is 10 centimeter morbid obese, then 10 plus 4, 14. So I cannot use this Veress needle, I have to use 20 centimeter Veress needle. That's why Veress needle is available in 8, 10, 12 and 20 centimeter length. 8 for junior pediatric, 10 for senior pediatric, 12 for adult and 20 for bariatric. So 4 plus, and you have to hold it like a dart. Not hold it here, don't hold like a pencil, don't hold like a pistol. Always hold like a dart. Dart is a game where you are throwing it. If I will tell you to aim it, you will hold this way, aiming it like that. You will never hold it like this. If you hold like that, can you aim it? You can never aim it. You cannot throw it. It will drop here only. But if I will tell you, when you are flying the aeroplane of the paper, you are holding like dart. Am I right? And then you are throwing it. So same way, what is the advantage? Automatically your elevation angle will be 45 degrees. And it is pointing towards NS. So 4 plus. This video is demonstrating you why 4 extra is used. See here, this is peritoneum and here Veress needle is tenting, that much tented. Why? Because first the blunt tip of the Veress needle has to go in. As I told you that there are 2 layers in the abdominal wall which is plastic. Plastic means need to be cut. First is skin and second is peritoneum. So this peritoneum need to be punctured by the sharp tip of the Veress needle. So sharp tip will only come in front if blunt tip is pushed back. And to pushing back, tenting of peritoneum is required to generate the sufficient force to push back the blunt tip. So that's why 4 centimeter extra. And now you see what happened. This blunt tip is pushed in and sharp tip has punctured. And now again blunt tip has come in front. Did you see that? So what is this length? 4 centimeter extra. If you will use the same length as you have the thickness of abdominal wall, you will make preperitoneal pocket. This is what beginners they do. If this is the abdominal wall and I am holding here, see, I am in preperitoneum. It is never going in because I need 4 plus thickness. Then this is first click, second click. Because this is also plastic structure. So 4 plus thickness of the abdominal wall, you should hold the Veress needle. After that, this blunt tip, when it touches the bowel, it won't puncture. So touching the bowel, but it is safe. So that's why this experiment is done to show you that where to hold the Veress needle, like a dart. And what should be the length of your Veress needle? 4 plus thickness of the abdominal wall. In morbid obese patient where they have 12 centimeter thick fat in the abdomen, fat is always either subcutaneous or retroperitoneal, means preperitoneal. So if that much thick, then you have to make that much naked. That's why 20 centimeter Veress needle. After that, you put the tip of the Veress needle into this stab and then leave the Ellis forceps. And then lift the abdominal wall with full thickness of thenar eminence and all the 4 finger, full thickness like this. You should not use a towel clip or Ellis forceps to lift the abdominal wall. That is bad. Because in some of the book it is written that towel clip should be used to lift. It will only stretch the skin. We don't need to stretch the skin. We need to lift the full thickness abdominal wall. So use your all the 4 finger and thenar eminence to lift the entire abdominal wall. How? We will see here. This is one small stab wound is given over the inferior crease of umbilicus. Then this is the Veress needle. You put it there and then lift the abdominal wall with your hand like this. And then it should be perpendicular to the abdominal wall and oblique to the body. Your direction should be towards the anus. And this is 1 click and this is 2 click. You are in. After that, you will take a syringe and then you will do irrigation test. This is the irrigation test. It should go freely. Suction test, nothing should come out. And then hanging drop test. Lift the abdomen, this drop is hanged in, sucked in. And then you will attach the tubing of the insufflator. And once the tubing of the insufflator is attached, after that you will use quadromanometric indicator. And your eyes should not be seeing on the abdomen, your eyes should talk with the insufflator. And this is quadromanometric indicator. All of us, we have already learned about the quadromanometric indicator. Already we have learned about the quadromanometric indicator. So I am asking you the questions now. And these questions you have to answer. So the question is that preset pressure is 12. Actual pressure is 0. Flow rate is 1 liter per minute and total amount of gas used is approximately 10 liter. Where are we? We are not in preperitoneum. This is a wrong answer. Pardon? Leak. Wait. First answer, preperitoneum. Now tell me, if our abdominal cavity itself has maximum capacity 6, Then how come 10 enter into preperitoneum? Can you put a 10-liter container inside a 6-liter container? And what are you thinking about the bowel? Can bowel take 10 liter? What are you thinking that you put the gas in a small bowel, then it go to cecum, then ascending, then transverse, then sigmoid, and through the anus push out? It doesn't happen. Bowel can never take 10 liter. Bowel will burst in 10 liter. And preperitoneum can never take 10 liter. Again, I will repeat the question. Preset pressure is 12. Actual pressure is 0. Flow rate is 1 liter per minute and total amount gas is 10 liter. Where are we? Only leak. Leak. It is leaking outside. Why? Maybe the cylinder is not attached. Maybe your connection of the tubing with the Veress needle is not tight. It is just loose, leaking. Or tubing is cracked, leaking. Because even 1 trillion liter gas you put in this environment, can you increase the pressure? And what is the environmental pressure? 0. Am I right? So actual pressure will remain 0. What is preset pressure? This we are giving the command to the insufflator, so that will remain 12. And insufflator is trying to increase, but it's not increasing, it is 0. All is 10 liter, 10 liter, 20 liter, how much liter you put? 0 cannot be removed. Am I right? Second question. Preset pressure is 12. Actual pressure is 12. Flow rate is 0.5 liter per minute. And total amount of gas used is only 200 ml. This is preperitoneum. Preperitoneum is just like the stretched gloves. This stretched one, this stretched gloves here. Just within, because preperitoneal space is not a preformed cavity. It's a artificial cavity. It's a potential cavity. Potential cavity, if we want, we can make it. But it is not made by God. Am I right? So, within 100 to 200 ml, it will, actual pressure will reach to preset pressure. So that's why in this question, preset pressure is also 12, actual pressure is also 12, flow rate is 0.5. Why? It is restricted flow. And within 200, total amount of gas is 200. Within 200 ml, our actual pressure reached to preset pressure and flow is stopped. Then flow is still continuing. You know, maximum capacity of preperitoneal pocket is 1 liter. After 1 liter, flow will stop. Up to 1 liter, restricted flow will be there. Why? It is stretching and fibrous trabecules of the preperitoneal space is breaking. Because peritoneum is attached with the muscle or posterior rectus with the fibrous trabecules, and that will break, it will tear. After 1 liter, it will touch the bowel and enough is enough, now it will not. Preperitoneum can never take 10 liter. Don't think about that. Maximum capacity is only 1 liter. So how you will know that your gas is going in preperitoneum? Within few seconds, your insufflator actual pressure will go double digit. It become double digit. Double digit means 10, 11, 12, within 200 ml. And what is the minimum amount of gas required in human? Yes. And if it is going, suppose means 1 liter, it is not possible. In the, and another within 200 ml, it is not possible to make the abdominal distended. Am I right? Minimum is 1.5. So within few seconds, if it is double digit, you are where? Preperitoneum. So easy. Quadromanometric indicator is such an intelligent instrument. Within 5 seconds, it will let you know where the gas is going. Third question. Preset pressure is 12. Actual pressure is also 12. Flow rate is 0 and total amount gas has only 100 ml. Where are we? Yes. Either you are in subcutaneous or in the muscles, anywhere above the posterior rectus. You are not in preperitoneum. Because what I told, preperitoneal space is a potential cavity. That's why we can do retroperitoneal nephrectomy. That's why we can do totally extraperitoneal hernia surgery. Because it is a potential cavity, means we can make this cavity. But in between muscle is not a potential cavity. Subcutaneous is not a potential cavity. So within 100 ml, your actual pressure will reach to preset pressure and flow will 0, stop. In preperitoneum, flow will not stop. Why? It is a potential cavity. And how much gas is required to stop the preperitoneal pocket? 1 liter, yes. Now, third question, means fourth question or whatever question. Preset pressure is 12 because we are keeping it 12, that 12 will be there. Actual pressure is 6. Flow rate is 1 liter per minute. Total amount of gas gone 12 liter. Where are we? Pardon? Major vessels means vena cava, not in aorta. In vena cava, aorta pressure is 120, so immediately your actual pressure will go more than 30, and your insufflator tet occlusion. Am I right? Because our gas can never enter into any artery, because artery diastolic pressure is 80 and our insufflator is at 12, so it can never put in vessel. It is in vena cava because vena cava pressure is 6. And as long as your flow rate is 1 liter per minute, even if you put 20 liter gas in vena cava, patient will not die due to air embolism. May die due to bleeding, that is another story. But air embolism will never happen because CO2 is 200 times more absorbable than oxygen and 20 times more absorbable than air. So as soon as it enters, it will keep on. That's why with the Veress needle, what we keep the flow rate? 1 liter per minute. And maximum capacity of eye of the Veress needle doesn't allow to go more than 2.5 liter per minute. Now next question. Preset pressure is 12. Actual pressure is also 12. Flow rate is 1 liter per minute. Total amount of gas used is 1 liter. And you have a unilateral distension. Yes. Then it is going in bowel. Whenever you have a unilateral distension, it is going in the bowel. If it is a suprapubic distension, most commonly in the bladder. If it is left iliac fossa, most commonly sigmoid colon, because it is often distended. That's why enema should not be used in any of the gynae surgery also. Enema has a problem, it will deflate the rectum, distend the sigmoid colon. And if it is epigastric, that means maybe in a stomach or sometime a small bowel. Why it is happening? Because sometime with the umbu bag, your anesthetist put a lot of air in the stomach get distended, and if you are putting supraumbilical port, you may perfectly. That's why even in gynae, NG tube should be there to deflate the stomach before putting Veress needle. So this is in the bowel. So this is very. Now question is, if these are abnormal setting, then what is normal? How I will know that my gas is going at correct place? Graph between actual pressure here and total amount of gas used should go this way, like a parallel. This is the actual pressure and here is the total amount of gas used. This is actual pressure. And this should go like that. The graph of the actual pressure and total amount of gas used should rise parallel like that. It should never meet, it should never divert. This is important. Why? Because this gradual flow is very important to have the satisfactory quadromanometric indicator. Let us assume that there is a 18-year-old man going to gym, he is young man, 18-year-old, and he is not very tall, average size, but muscular and thin. How it will behave, I will tell you. As soon as you put Veress needle and start distension, within 100 to 200 ml, first thing what will happen, liver dullness will get obliterated. You will get a sound like a ripe watermelon. It is not a true tympanic sound. For true tympanic sound, you have to put your hand and tap it like that. But we are not doing tapping, we are doing just palpation. So it will give a sound like a ripe watermelon. After that, within 400-500 ml, your actual pressure will come 3, 4. After 1 liter it will become 6, 7. After 1.5 it will get 8, 9. After 2 liter 10, 11. After 2.5 or 3, depending upon how tall he is, reach to 12 or 15, whatever preset pressure, because your insufflator is made to keep the actual pressure nearer to preset pressure. As soon as actual pressure comes to preset pressure, flow will stop. Another example is very tall, grand multipara woman. She is 65-year-old, delivered 4, 5 babies, very tall. In her case, what will happen? Again 100, 200 ml liver dullness will get obliterated. But within 1 liter, you will see your actual pressure is only 2, 3. After 2 liter, actual pressure will come 4, 5. After 3 liter, it will come 8, 9. After 4 liter, it will come 12. And after 5 or maybe up to 6, it will come 15. And abdominal will be doom like that. Because she has a lax abdomen. And same happened in postpartum laparoscopy. Suppose patient is delivered today and you want third day to do tubal ligation or any other internal iliac ligation, there is a postpartum hemorrhage started. Then the woman that post delivery can take up to 6 liter gas. उसका abdomen इतना lax होता है ना, that is post pregnancy laparoscopy is very easy because you have a huge big abdominal cavity. Throughout the surgery it was stretching, and right now just after delivery it cannot return back, so up to 6 liter of the gas. So this you have to develop your intuition. Even if you are inside a car, your driver is driving the car and you are seeing the people walking on the road, you should decide she will take 1 liter, she will take 1.5 liter, he will take 3 liter, and you will be surprised after few time your this guess will be the best. So as soon as patient enter in the OT, in your mind quadromanometrics should start blinking. She is walking on the stair to lie down on the operation table, और आपके दिमाग में calculate हो जाना चाहिए. You have to calculate in your mind how much she will take. And you will be surprised after few experience, exactly only 100 ml plus minus, your calculation will be correct. That how much she will take. According to what are the variables? First variable is size. A small girl of 4.5 feet and a tall girl 6 feet will have different, same man. Second variable is what? Muscle relaxation. If you are doing under general anesthesia, you will be able to put more gas because you will have intubation, ventilator and muscle relaxation. So abdomen can stretch more. That's why laparoscopy is preferred in the which anesthesia? Yes, local anesthesia. Third variable is what? Third variable is bowel preparation. If bowel is prepared nicely, your patient was giving Pegleg powder, polyethylene glycol prior to the night of surgery, you will be able to put more gas, and more gas means more safe, isn't it? More safe, because more gas means I have more space in between the bowel and abdominal wall. And if the patient has no bowel preparation, already she has a nice dinner prior to the day of surgery, you will be struggling in the surgery. And fourth variable is any space occupying lesion. Big fibroid, big ovarian cyst, pneumoperitoneum, ascites, you will be able to less gas. So suppose already patient has 12-15 centimeter ovarian cyst, you cannot put minimum 1.5 or maximum 6. In only 1 liter it may become 12. Am I right? Or patient has rupture ectopic, already 1.5 liter blood is inside. Then you will be full within 500 ml. Because already 1.5 liter is occupied by the blood, and so that's why this intuition is very important. You have to develop, and this is the importance of this quadromanometric indicator. Blindly layman type से ऐसे palpate करके नहीं decide करिए. You should have the, that's why I told you laparoscopy has 3 important pillars. First is what? Ergonomics. Second is what? Task analysis. And third is what? Engineering. And engineering of insufflator is a super intelligent instrument. it has bidirectional. It is not only going in, it can take the gas back. And it can sense that what is you using. You are using Veress needle, you are using trocar, you have a occlusion, you have the venting system active, you have a RTP relay transport protocol active, and it is warming the CO2 at 37 degrees centigrade and then putting it inside the abdomen. And if anything extra pressure happen, it give you alarm, that means somewhere else. Suppose you are irrigating a lot of saline, it can take the gas back as well. So this is quadromanometric indicator. After that, once you confirm the quadromanometric indicator, then what you should do, you should extend the incision to laburnum. Extend the incision to laburnum. And then you spread the fatty tissue with the Kelly clamp. Kelly clamp means a small mosquito forceps, you dilate. And in that process of dilating, actually you are opening the vitreointestinal tract. That is important. That is a part of a Scandinavian technique. And then this is how you will dilate subcutaneous tissue or open the obliterated vitreointestinal tract. After that, you will hold the trocar like a pistol. Trocar should not be held any other way except like this. How to hold the trocar? The head of the trocar should rest over the thenar eminence here, as a. Middle finger should wrap around air inlet and index finger should be pointed towards the sharp end. कुछ लोग ऐसे पकड़ते हैं, क्या पता क्या क्यों? If you hold it like that, it will boom enter. And if this trocar is not touching your thenar eminence, this trocar will come back. And with the cannula you are struggling, it will never go. So head of the trocar must be pressed by what? Thenar eminence. And middle finger should wrap around air inlet and index finger should be pointed toward. This is the only way to hold. If this middle finger is not entangled over the air, ऐसे पकड़ लें तब भी गलत है. This is wrong. Your middle finger and thenar eminence must be pressing against each other like this. This pressure. Middle finger and thenar eminence must be pressing each other and index finger should be pointed towards the sharp end. And after that, by a screwing movement like this, you should have full screwing. Don't push, because you have a pyramidal shaped trocar, and keep on doing like that, and slowly you will take your time and you will enter inside. Here also tenting happens and then you enter. So if your index finger is here, it will stop you fully entry, because it is guarding you. This is index finger which is guarding me to enter fully. And pressure should be over the thenar eminence. So this is very important, how to hold it like a pistol. Here you can see the middle finger should wrap around air inlet, index finger is pointing towards the sharp end. And then your movement should be supination, pronation. ऐसे नहीं करे. Fully 90 degree like this. Pronation, supination, pronation, because this pyramidal shape will drill, it will not puncture, it will drill it. So extend the incision like that. After that, take a mosquito, dilate the obliterated vitreointestinal tract and then hold the trocar like a pistol. Index finger must be pointing and then slowly screwing, you are in. As soon as you are in, you will get a hissing sound, because tip of the trocar has one eye which is leaking the gas from the back. That is called whooshing sound or hissing sound. And then take the trocar out. After that, again connect the tubing of the insufflator, and then by the time white balancing and focusing will be done by your camera person, keeping white gauze piece in front. This is white balancing and focusing at how much distance? 10 centimeters. And then you will introduce the telescope inside. And as soon as telescope enters, first you must look just below the entry point to find out any inadvertent bleeding. Some few drop of blood always will be there. So you should not confuse like a bowel perforation, because it is a trickled blood due to umbilical wound. थोड़ा सा blood रहेगा, चौंक मत जाइए कि I have injured something. That is trickled blood through the umbilical wound. That is normal. After that, you will see which quadrant you have to perform the surgery, and then you start performing the surgery. If patient is pediatric, you have to be more careful. because very thin patient and very obese patient, both are risky to perform surgery. Access. So here this is a small pediatric patient, and this is the, you have two Allis forceps applied either side to evert the crease of umbilicus. And this is a small stab wound is given over the inferior crease of umbilicus, only 1 millimeter. Then you will measure the thickness of abdominal wall like that. And suppose it is 1 centimeter, because it is a very thin boy, poor boy, then 1 plus 4, 5 centimeter of the Veress needle is naked. The rest of the entire Veress needle is guarded. केवल 5 centimeter naked है. All the other part is guarded. You have to hold it like a dart, and then drop the Veress needle into the wound first. Here it is dropping into the wound first, and then lift the abdominal wall. Purpose of Allis is not to lift the abdominal wall, just to evert the umbilicus. We have a temptation को इसी को पकड़ के खींच देते हैं. Don't do that. So hold it, and hold it by thenar eminence and all the forefinger like this, and then you will lift it. And if you see very carefully that here is the abdominal wall. This is the abdominal wall. Can you see that? At what is this angle? 90. And in relation to body, what is this angle? 45. And it is pointing towards what? Anus or aorta? Towards anus. Remember, if you point towards the anus, then never ever in your life you will injure aorta or vena cava. But without lifting, if you will point towards the anus, there is a potential risk of going to preperitoneal pocket, because your Veress will be slide over the preperitoneum. So you have to be perpendicular also and oblique also. Perpendicular to what? Abdominal wall, yes, and oblique to what? Body. So you are both perpendicular as well as oblique. You will never go to the any great vessel, and it will not make preperitoneum. And after that you will go, and this is 1 click and this is 2 click. Because in middle line throughout from Giphy sternum up to pubic symphysis, you have only one rectus sheath along the linea alba, anterior and posterior fused together. So first click is due to rectus, second click is due to peritoneum. You may not hear the click, but your finger will feel the click. Hearing is not possible in the noisy operation theatre. After that, you will take a syringe and you will attach the syringe. And this is irrigation test. This is irrigation, this is suction. Any amount of fluid which you have irrigated should never return back. If it is returned back, that means you are not in the abdominal cavity. Am I right? And if more fluid has returned back, that means either patient has ascites or you are in bladder. If red fluid came back, that means either patient has hemoperitoneume, or you are in vessel. So if it is a hemoperitoneume, dark red will be there. If you are in vessel, you will get bright red. After that, you will do hanging drop test, and this is hanging drop. See, this drop is hanging, and then as soon as you lift the abdominal wall, this hanging drop will be sucked in, and that is the another test. And then you will attach tubing of the insufflator, and then you start insufflating. As soon as 100 ml, 200 ml gas has gone, then you will palpate and you will get the liver area will get obliterated. The first thing, because this is a potential space. That's why in the perforation of the bowel you are doing gas under diaphragm, because even in bowel perforation, gas first reach to the subdiaphragmatic area on the left side. So you will palpate, and then your eye should be here. Your eye should be looking at your insufflator. You have to talk with your insufflator. Now check the insufflator here. You see, I will show you. The mode is what? The mode is pediatric. Can you see that? This is pediatric mode, see. And what is the set pressure? 8. What is the actual pressure increasing? What is flow rate? 0.7. So in pediatric cases, your flow rate should be 0.1 liter per minute per year of the age. If the child is 1 year, then 100 ml per minute, 2 year, 200 ml, 3. You know, as soon as you will put pediatric mode, automatically insufflator will, by default, will set it to 0.1. And by default, it will set to 8. By default, वो खुद ही set कर देगा. Because they don't have any belief on you कि surgeon को आता नहीं आता, but it will do its own. And then if 7-year-old, you can increase to 0.7. And after 10 years, it will be 1 throughout the life. So this is quadromanometric indicated, and then you will start insufflating, and once it is insufflated, then you can see here there is some fluctuation, 6 8 6 8. Do you know why? Because of movement of diaphragm. Now you may ask your question that how much gas is required in pediatric patient? Minimum amount. For adult I told you minimum 1.5 and maximum 6. In pediatric into 2 by age. If it is a 3-year-old child, within 600 ml her abdomen will be full. If it is 4 year, 800 ml. 5 year, minimum 1 liter. And after that, once it comes 10 year, then 2 liter, 1.5 to 2, depending upon. Because after 10 years, they behave as like adult. However, according to the pediatric age group is 14. But laparoscopically, after 10, we consider adult to perform. It is not necessary to send the patient to pediatric surgeon. Actually, we never send the patient to pediatric surgeon. But if you want, you can do that. So this is how we can perform the surgery. After that, you will extend it a smiling incision. This is a smiling. Either side, sharp edge of the 11 number knife should be put outward. Outward, ऐसे करके क्रश करना है, outward. Why? Because only a skin is required to cut. तो ऐसे ऊपर लगा, hook anteriorly, don't stab. Hook it outside. This is called a smiling. So sharp edge is outward. Half this side, half other side. Sharp edge outward. And cut it anteriorly. Don't cut it posterior. Don't keep the sharp edge down. Because you are only allowed to cut by your knife the skin. Rectus should never be touched. And it is cut. After that, take a mosquito and dilate the obliterated vitreointestinal tract. Usko stretch करें. Take your time. Any uncut septa of a skin also will break. And then you will hold the trocar like a pistol. Here you can see head of the trocar is more guarded. Tip of the and index finger is more guarded. In adult, if this patient would have been adult, your index finger may reach up to here only. One point I would like to emphasize that female ko thoda, ladies doctor ko, ladies gynecologists, they have problem because their hand is small, so it reaches only up to here. So if your hand is small, you thumb over the tip of the trocar, yahan, thumb. And then your index finger will elongate. You got it? So if the ladies with the small hand, don't put the thenar eminence. Otherwise your index finger will reach only up to here. The small hand, it is only here. So you measure it yourself that how comfortable you are, and then tip of the thumb, this must be closed. And pressure should be applied from here. Am I right? Because what is this? Trocar. And if you not push it, it will never go. Because trocar will come back and cannula cannot go alone. So how to push? By thumb. And put the, and this elongate the, like this. This is the way to hold for ladies with the small hand. And in pediatric patient, even the general surgeon, man also should hold like this. Because I need that much only naked. So that my index finger will stop me inadvertently going fully in. ऐसे पकड़ेंगे, you will hit the bowel or vessel. So, see, more it is guarded in pediatric. And after that, just hold it here. If you will see SAGE's guideline, then in SAGE's guideline, they have recommended that you may increase the pressure up to 25 before putting the first trocar. In SAGE's guideline number 1. But later it is not emphasized, and if you are holding the abdominal wall yourself, then it is better, because sometimes we forget that 25 was there and we have not reduced, then it is dangerous. As we have discussed in advantage and disadvantage of minimal access surgery, that as soon as pressure go from 12 to 18, all the quadromanometric indicator will become your, this complication rate will become 4 times more. What are the complications? Of the more gas, air embolism chances increases, end tidal CO2 concentration increases, am I right? It is CO2. Renal perfusion decreases, then you have the problem with the venous return decreases, cardiac output decreases, DVT started forming, microatelectasis started forming, cerebral arterial dilatation, cerebral edema, bradycardia, all increase 4 times if you will not see that what is happening. So this is very important and you should take care of that. Now, if the patient is obese, then also you have to be more careful. This is a mini gastric bypass surgery, MGB surgery, and in that here is the inferior crease of umbilicus. Veress needle is better to put through the inferior crease of umbilicus. However, trocar you can put supraumbilical. Because if you will put the trocar into the umbilicus, you may not be able to perform the surgery. So this is supraumbilical, and this is how you will enter. And once you have entered inside, you in obese patient doesn't mean bariatric surgery. Obese patient, even for gynecologists, you have an obese patient. You will not tell the patient, if you have an obese, that go first get bariatric and then come to me, I will do hysterectomy. You have to do it anyway, even if the obese. If you go to Saudi Arabia and all, 50% patients are obese. Am I right? For gynecologists, वहाँ आराम से ऐसा पेशेंट नहीं मिलता है जैसा हम लोग को मिलता है. Most of the ladies are obese. So what you have to do, you have to give one small stab wound over inferior crease of umbilicus. After that, take a Veress needle. If you are using cellophane dressing over the umbilicus, Ellis forceps cannot be applied because वो तो cover हो जाता है umbilicus. Then only you cannot apply it because it will tear. Cellophane dressing means a sticker type of dressing on the draping. It has advantage that infection is less because it doesn't erode the bacteria of the hair. So you will put the Veress needle and then you should ask your 2 assistants to lift the abdominal wall. Alone you will not be able. And see here, again it is perpendicular to the abdominal wall but oblique to the body. So in obese patient, ladies with the soft hand, you should not lift your own. You should ask the assistant who is standing in between the leg for your triangle manipulator to lift him. Am I right? Or 2 assistants, one is holding this side, one is holding that side. Because your hand will slip. And then you are perpendicular, 1 click and 2 click. You are perpendicular to abdominal wall and oblique to the body. And you can see our entire Veress needle has gone in. Why? Because it is morbid obese patient, and then this is irrigation, and then suction, and then hanging drop test. After that, once you will hanging drop, ask assistant again to lift, and it is sucked in. Why? Lifting will create further negative pressure, and it is sucked in. After that, you will attach the tubing of insufflator, and your eyes should look where? Over the insufflator. Talk with the insufflator. Your insufflator is ready to tell you that what is your success. Within 5 seconds, it should become single digit. It should never become double digit. Otherwise, you are wrong. If you are wrong, immediately take it out, reintroduce. But if you will not appreciate it, and once you have 1 liter gas has gone inside, and then you will go, then you will see that absolutely there is nothing is visible. 1 liter gas has already gone inside. Then even if you take Veress needle and again reintroduce repeatedly, you will go in the same pocket. And after that, what will happen? Your trocar also go, your telescope will also go, and then you will think that this patient has some problem because it doesn't have bowel. So, but you have not punctured the peritoneum. So now what to do? Suppose already I have made a 1 liter preperitoneal gas and I enter into that preperitoneal space. There are 2 options only. One option, turn the direction of the telescope outside and bluntly puncture the peritoneum. It is a little risky. But because tip of the telescope is blunt, so generally it doesn't perforate the bowel. If it is adhesion also, bluntly puncture kare. If it is omentum, it will open the jungle of omentum and boom, peritoneum will rupture and you are inside the abdomen. Because if you have made a huge preperitoneal pocket 1 liter, then again Veress needle or trocar will go in same pocket. Don't think just by taking the gas out, peritoneum will reattach. Once it is sagged, it is broken, it can never reattach. So puncture the peritoneum because all the preperitoneal goes to the lower abdomen. Upper abdomen will be still virgin. That area where peritoneum cannot, gas cannot go. Because gas only go to the lower abdomen. Upper abdomen gas never goes. Because in upper abdomen, what is the advantage? That it is lower abdomen. Why all the preperitoneal gas go to the lower abdomen? Because below the arcuate line there is no posterior rectus. So that is a potential space. Another advantage is that in that area, you know, due to bladder, peritoneum is always getting separated, because bladder is preperitoneal, and once bladder distend, it stretches the peritoneum. So that is a potential space. You can never expect the preperitoneum at Palmer's point, not. So if you will puncture upper peritoneum and enter into it, it is fine. Otherwise, remove it and go with the Palmer's. And if you have failed in the umbilicus, and if you go to the Palmer, then that gas through the Palmer will push the peritoneum again back. Because now there is no negative, there is a positive. By default, abdominal cavity has a negative pressure. So that's why broken and teared, stretched preperitoneal pocket, peritoneum can never go again back. But as soon as with the Palmers we will start insufflating, this positive pressure will push the peritoneum back. And then you can put trocar in the umbilicus. Only Veress needle in the Palmer. Am I clear to you what I meant to say? Trocar is not necessary. केवल Veress needle यहाँ से डाल दें and insufflate with the Palmer. That's why many people routinely they insufflate with the Palmer. And then this bad preperitoneal will again pushed up, and then you put the trocar through the inferior crease of umbilicus. So this is important to keep in mind. Now Palmer's point. Palmer's point or Mishra's point, you have to stretch it down. In Palmer, stretching is not required. And then here you will get 3 click, and your direction should be must be towards the stomach. You should try to perforate the stomach, then you are safe. If you will try to save the stomach, you will puncture. If you will go like this, you will puncture the splenic flexor of colon. You will go up, you may injure the spleen. And splenomegaly is an absolute contraindication of using Palmer's point. Absolute contraindication. And nasogastric tube is must. And then 3 click. First click, and then second click, and then third click. 3 click you will do, you are in. After that you should take a syringe, and then you will do irrigation test, suction test, and hanging drop test. So after that you attach the tubing of insufflator, and your eye should look for quadromanometric indicator. This patient has incisional hernia, so Palmer is mandatory. It is not your choice. You have to go with the Palmer. There is no other option. We can see this hernia is bulging, and around that massive adhesion was there. So if you will go supraumbilical or umbilical, impossible, because this is a incisional hernia. So Palmer, and trocar also should be pointed directly towards the stomach. And then by a screwing movement you will enter, then hissing sound will come, take the trocar, introduce the telescope and perform. Now open technique. Why open technique? Because blind is blind. There is always a definite small risk of injury with the blind technique, irrespective of the experience of the surgeon. Blind is blind. You can never 100% guarantee that you are safe. Because in blind technique we consider that we expect that everything is okay below the umbilicus where I am putting. This is our guess. We are expecting it. But we may be wrong. When the patient was 3-year-old child, she fell down from the bed. One of the hard object has hit the abdomen. For that, parents took her or him to the hospital. For 3-day injection was given, IV fluid was given. Eventually, the baby got relieved. After 30 years, he or she will never remember which abdominal trauma happens when she was or he was 3-day old. Even their parents will not remember. And due to that, bowel is adhered and your trocar has hit the bowel. Definite a small risk is there. You have sent the patient for pelvic ultrasound. Ultrasoundologist has focused only on uterus and ovary. Patient has a aortic aneurysm at the bifurcation of common iliac vessel, big aneurysm. And ultrasoundologist doesn't see that because he was focused only to the pelvis. And you put your Veress needle and it has hit the aneurysm and patient die on the table. So blind is blind. Blind technique always has a little potential risk of injury. So for that, Hassan has invented this Hassan port, and he has invented with the conical tip and blunt trocar. Conical tip, that is called Hassan cone. This is Hassan cone. This is Hassan cone. A cone hai. And this trocar is blunt. This is blunt trocar. Only you have to buy these two things, this cone and this trocar. Hardly Indian company will charge you 800, 1200. This is blunt trocar and this is a blunt cone. And after that, any of your previous trocar, like suppose this trocar, this port, this trocar we will remove, and this blunt cannula we will put. And then this cone you can attach it by the screw here. There is a screw, you will release it, and then it will enter inside. And now it is in. And then according to thickness of abdominal wall, you tight it. It can be pediatric, it will be here, normal here, obese here, and tight it. And then it is become Hassan port. This is Hassan port. So it is very safe, very easy. There is a slit here. And purpose of slit is to entangle the suture. So Hassan technique, you have to take the bite either side like that, either side on rectus sheath, stretch it, take a S retractor and drop it conically, and then check the trocar out. And then there is a slit. Over this slit you have to entangle the, like that, and just you will entangle it this side and then entangle it other side here. And as soon as you entangle it like that, it's over. You should not tie a knot, because at the end of the surgery, same suture will be used to close the port. And see, because it is suture, so it won't come out itself. So this is a Hassan technique, and Hassan port was invented in 1974. So how to do? You will give one modified Hassan technique is also there. So give one incision over the inferior crease of umbilicus. Remember, Hassan is also never done transumbilically. And after that you apply 2 Ellis forceps either side, then clean the superficial and deep fascia by opening the seizures. You will clean it. And after that you have to put it there, and then you will clean up to rectus sheath. After that you take a coaxial and hold the rectus sheath. This is very important, that you have to clean the rectus sheath. And good thing about that, in midline you have only one rectus sheath. दो rectus sheath नहीं होता है in midline, only one rectus sheath. And then you take one another coaxial, apply from other side, and then your assistant will lift the rectus sheath towards the anterior and he will pull it like that. This pulling is very important, because this is keeping you safe, because there is no pneumoperitoneum. And then with the knife you will cut perpendicular to the rectus and in between these two coaxials. But remember, when you are cutting it, never ever cut the peritoneum. You are only allowed to cut the rectus. If you cut the peritoneum, then the Hassan technique is worse than the Veress needle technique. Because if the bowel is adhered, you will stab the knife. So only allowed to cut the skin, clean the deep fascia, hold 2 coaxial, assistant will lift, and only cut the rectus. And after that you remove and you take a blunt artery forceps, and you have to puncture the peritoneum bluntly, blunt puncture of the peritoneum, so that even if the bowel is adhered, it will displace away. And then stretch it, just like the birds which digs the tree. You have to open and stretch it. After that you use 2 small S retractors. These are called S retractors. And then take a bite on the either side of the rectus. Deep bite you will take on either side of rectus. This suture should be kept long, because it will use to hold it stabilized. And this is omentum now, because there is no pneumoperitoneum, so omentum comes. And that's why our trocar is blunt. And according to the thickness of abdominal wall, this cone, Hassan cone, has to be adjusted. And then tight the screw here, so it will not come out or in. And then drop it, and then you will slowly remove the S retractor. because this is blunt tip, so it will push the momentum away. This small S retractor is essential for Hassan technique. Matlab, without that also you can do, but you will struggle. S retractor is very important, a small S retractor. And both the S retractor you will take out, and after that attach the tubing of insufflator and then entangle it over this slit. Remember, in Hassan technique also, your flow of rate of the CO2 should be 1 liter per minute, because rapid insufflation can create vasovagal shock. So you should use 1 liter per minute, and then you will, at the end, the same suture will be used to close the port. In Hassan technique, port closure is must, otherwise there is a 100% chance of hernia, because your port is never 10 mm, it go 12 to 15 mm, because it is a manual laparotomy. You cannot guarantee that my port is equal to the cannula. In open technique, always hernia has there, that's why port closure is must. Port closure means, and here bite is taken on the rectus, so it will close, no facial closure, port closure. And that's why this bite we take in the beginning itself, because it will stabilize the cannula throughout the surgery, and at the end the same suture will be used to close the port. How far Hassan technique versus the Veress needle technique? Hassan technique is superior than the Veress needle technique, but it is slightly superior as far as the bowel injury is concerned. In Hassan technique, bowel injury has been recorded, and it is not very safe if there is a extensive intra-abdominal adhesion expected. In those situations, Palmer's point is safer than the Veress needle. Another drawback of Hassan technique, in morbid obese patient, Hassan technique is difficult, because they have so much fat subcutaneously कि आप tunnel में चले जाएंगे, your S retractor will be lost, because it is too deep. You have that much fat in the subcutaneous area. So Veress needle is better in morbid obese patient. Other drawback of the Hassan technique, it is only possible in the midline along the linea alba. You cannot use it for the Palmer's point, it won't work. Or for retroperitoneoscopy in between costal margin and iliac crest, Hassan technique is not possible. So these are the few drawbacks, that's why, but it is particularly good if you are expecting intra-abdominal adhesion. If you will do a review article, Hassan technique versus Veress needle technique, that ultimately at the end of conclusion, they have considered Hassan technique is slightly superior than the Veress needle technique, but it depends upon the preference of the surgeon. They don't insist you that this technique is far superior than other. It is not. It is the experience of the surgeon and preference, and particularly the surgery what you want to do is important. Now VG port. VG port was introduced in year 2000, and once it was introduced, it was a big sound all over America and all over world, of course, that it will create a revolution in the access, because everything is under vision, and that's why name was VG port. Forget about the injury to the bowel, aorta or vena cava. During entry I am giving you the vision, and that was the idea of the VG port. But once the VG port was introduced, within 2 years, 10 perforation, 2-3 years, 5 to 10 perforation were reported. After that, US FDA has banned it, that it is worse than the sharp trocar, because it is doing bowel injuries. Then 2 years later, they again requested the FDA that please give me permission again. It is from Auto Suture company. Auto Suture, Tyco, Covidian, Valley Lab, Medtronic is same company. So then Valley Lab, Auto Suture, then FDA has told that no, it is not good, it is risky. Then they said that okay, we promise that we will tell our customer to use it after creating pneumoperitoneum, not under vision directly, blindly. Then they said that okay, we will give you permission, but you have to put a notice, warning inside the pack. Then first warning they put it very small, very small warning like that. Then FDA has told no, this will not work, you have to take big warning. Then now they are keeping it 2 papers, this is one small and then another big. Do not use in the abdomen without pneumoperitoneum, a strict warning. You must have to use Veress needle if you are using VG port. Otherwise it will perforate, because it is a misnomer, nothing is visible. So how it works? It has a optical trocar with the normal cannula. This is a pistol grip trocar. It has a optical tip, transparent visible tip, optical tip. And pistol grip, it has a trigger. There is a trigger. You will feel like you are police and you have to fire. And it has a hole there. And in this you will first put the Veress needle, insufflate the abdomen, and after that you will do 0-degree telescope, do the wide balancing, focusing, introduce telescope in the trocar, pistol grip trocar, and then this is 0-degree. 30-degree you cannot use, 0-degree is must. Why? 30-degree will show you by the side. So while you are entering, you will not see the tip of the trocar, and tip of the trocar is only side wall of the cannula will be visible. So you need 0-degree, and after that you press over the abdomen and then fire this trigger. With firing this trigger, every firing 1 millimeter blade comes out, and this blade will cut layer by layer. See, this is the blade, and you will keep on firing and firing and firing, and this blade, and see, this is the blade which comes out, and layer by layer by layer by layer it will cut and it will enter inside. So this is just a dummy. I will show you now the actual clinical footage. This is actual clinical footage. In reality, nothing is visible. Do you know why? Because your eye is touching the object. If eye touches the object, what will you need? Some distance to look anything. So this is touching like that. So you have just the little bit idea that something is visible, and you can see this is the preperitoneal fat. Then this is the facial layer, then this is the again preperitoneal fat, and then this is peritoneum, and then you are in. So this way you have to enter with the VG port. But my question is, if already I have used Veress needle, created pneumoperitoneum, then how far it is good? And some other companies, they are making the optical ports. Those are not VG port. VG port is a trade name of Johnson, this is auto switcher company. This is optical port. This is better than the VG port because it has a pyramidal tip. It doesn't have blade. So it is better. You can put the telescope, and then by a screwing movement you can attach camera here, and then by a screwing movement this way you can enter inside. So this is much better. These are available in 5 mm and 10 mm both. These are the VG. It is VG port is a trade name. So these are called optical trocar. Cannula is same, only trocar is different. So these are bladeless, and bladeless is better than bladed trocar. So this is also one of the option of the entry. Another option is Ternemian trocar. Ternemian was a German surgeon who has invented it. It has a sharp blade-like tip. You can introduce telescope also together and screw. You have to keep on screwing it, just like how you are tightening a nut, and slowly it has a thread and it will take you in. So this is called Ternemian trocar. Ternemian is a German surgeon who has invented it. The Starz is marketing it. After that you have a step trocar. A step trocar is a radially dilating trocar. It has an advantage that you have to cut only a skin. The rest of the layers you don't need to cut. You will put first 3 mm, and then you will pierce this 10 mm inside this 3 mm, and after that this 3 mm will dilate and it will outside sheath will break. Just like how you are using condom, or same way how you are using plastic IV cannula. Once you put, then take needle out and then inside is only plastic. It has 2 advantages. One advantage, hernia doesn't happen because only a skin is cut, the rest of the layer is radially dilating. And other advantage, it can never be reused because after one use it breaks. So reuse कर ही नहीं सकते, because in developed country there is a corruption. Once they have used it one time, then they sell it to developing country. उसको पैक कर देते हैं फिर से. Like suppose this VG port they have used. So what they do, that they open it like that, ये खुल गया, and they will open it and like that, and after that they again pack और उसको glue लगा के again they will stick it. This is open, this is closed. This is open, this is closed. And they apply some glue around it और उसको चिपका के फिर इंडिया में push. India, Pakistan, Bangladesh, they push. And in the grey market, these reused instruments are used because in India anyway they reuse it. Am I right? So if one use, what is the problem? Because anyway they reuse it. They reuse it harmonic, they reuse it ligashore. तो चलो एक बार use कर लिया, American use किया अच्छा है. So this is how they do it. But this is now our government is banning that refurbished kachra should not come to the India. And they are banning. It is good also, bad also. Good is that all the refurbished your camera, Striker 1880, 1188 or older camera, Olympus endoscope refurbished, 90% of the hospital they use upper GI, lower GI endoscope refurbished. Because suppose any new generation came, then old generation they sell it to developing country. So those are stopping now. So you have to buy brand new, it will be 10 times expensive, isn't it? Like if you want endoscope 4-5 लाख में आपको refurbished मिल जाएगा, but if you are brand लो तो 25-30 लाख में मिलता है. So that is good also and bad also, good also. Anyway, so that's why a step trocar this doesn't have problem, because once you use and you pierce this on that, it breaks. So because it is called radially dilating trocar. So this was regarding the access technique. Access technique here, first part I have discussed. In this part we have only discussed regarding the primary port, how to put optical port. The second part of this will be secondary ports. So welcome back. Now in this part of the presentation, we will discuss the secondary ports. The primary port we have already discussed that there are 6 sites of the primary port: supraumbilical, infraumbilical, superior crease, inferior crease, transumbilical and Palmer's point. So it is straightforward. And another big advantage is that once you have put this port, after that it goes in the hand of your camera person. So primary port is mostly concerned for the safety reason, that if you have not entered carefully, it may injure the bowel, injure the vessel. That's why in access technique, bowel injury is 1%. 1 in 100% bowel get injured. However, most of the injury is not leading to complication, because 90% of the stab only created by Veress needles goes unnoticed. Self-limiting. It repairs its own. And that's why needle is used. Purpose of Veress needle to introduce is to prevent the injury of trocar. Am I right? This is the only purpose of Veress needle, to prevent injury of trocar. Otherwise you would have done direct trocar insertion. So once you have safely entered inside and your telescope is in, then it goes in the hand of the assistant. So ergonomical point of view, you are now not holding it. Of course your assistant will struggle and you can shout on the assistant that you are not holding it properly. And he has to struggle more if it is at wrong place. But secondary port, if it is wrong, throughout the surgery, your ergonomics will be challenged. Then you will keep on crying and your assistant will smile. So in this situation, you have to follow baseball diamond concept. You know, laparoscopic instrument works on the lever function. Basically, it's a lever. And abdominal wall acts as a fulcrum. And length of the instrument which is inside the abdomen is called load arm. This is load arm. Load arm means where the load is. And length of the instrument which is outside the abdomen is called force arm, means where we are applying our force. And the abdominal wall is a fulcrum. Just like the balance which is by weight for weighing the things, shopkeepers they are using balance, and anyone, even if vegetable seller or diamond seller, they use balance to weigh the things. Nowadays electronic balance is also there, but we are talking about normal balance. So one side they are putting weight, other side they are putting good, and in the center it should be fulcrum. So exactly same way we do laparoscopy. One is force arm and other is load arm, and abdominal wall must stabilize your instrument. Without stabilizing the instrument with the abdominal wall, you cannot do laparoscopy. And ideally, this should make a class 1 lever. There are 3 types of lever: class 1, class 2 and class 3. In class 1 lever, fulcrum must be in the center, and the length of the load arm and the force arm should be equal. Just like the shopkeepers, when they do balance, they always keep fulcrum in the middle. If it is on one side or other side, that means he is cheated. He is cheated, he will not weigh honestly. The same way, always our abdominal wall should be in the middle of the instrument, so that your force and load will be equal and opposite. If you will apply 2 cm down, this will go opposite 2 cm up, or vice versa. And your surgery will smoothly, it will go. You are putting it down here, it is going up there, and it will be fantastic. Everything will go equal. But problem start if this fulcrum is shift to one side. Now this become class 2 lever. And class 2 lever, what will happen if you will reduce the force also? Here force is reducing now. Then also inside force will not reduce. Why? Because in class 2 lever, force is magnified and movement is rectified. In class 3 lever, movement is magnified and force is rectified. Here we can see this is an example of class 2 lever. This is a thin boy who wants to lift this heavy object, and he knows that alone he cannot lift this object, but he is intelligent. So what he is doing? Bringing some books, keeping a big rod, and this arm of the rod is short and this arm of the rod is long. So what will happen? His force will magnify, yes, and movement will rectify. Every day-to-day life you are seeing this. If some tree is fallen in front of your road and alone you cannot lift it, you are bringing a bamboo and dragging it. What is this? Class 2 lever. And your force is magnifying, movement is rectifying, and you are making a class 2 lever. Another example, this, here you can see fulcrum is here. This is the fulcrum. And to lift this 50 pound of the girl, this 200 pound man is sitting there. So force is rectified. And he is moving only 1 feet, this girl is thrown up 9 feet. Movement is magnified. Class 3 lever is used in the diving platform of swimming pool. One side of this diving platform is attached with the wall, and fulcrum is very near to the wall. And then you keep on walking over the tip of this, and you jump, you will be thrown up, because it will fly over. It will jump high and come in the dive in the swimming pool. So class 3 lever, what happened? That movement is magnified and force is rectified. So this is simple physics. Now I will show you just the example. Let us assume that this is appendix, okay, and this is my instrument. Half in and half out, and movement is equal and opposite. Fine, everything is going fine. Now I am going nearer. If I go very nearer like this, you see what happened. Outside my movement is 10 centimeter. Can you see that? And inside movement is 1 centimeter. And if I go very nearer, my elevation angle will become 90 degree. Elevation angle is the angle between the instrument and body of the patient. This is 90 degree. And you will get direct coupling. What is direct coupling? If you use current, this current will from the instrument will come to the cannula, And if cannula is touching, suppose cecum is here, cecum will burn. This is called direct coupling. So always this insulation should be in the cannula. This tip of the naked metal part should never touch. Tomorrow I am going to discuss the electrosurgery, then I will show you what is direct coupling. So this is the problem, and your elevation angle increases and force magnified. So if you want to take a bite, it will tear, cut through, and movement rectified. Now this is another story. Here elevation angle decreases because I am far away. If I am half in and half out, elevation angle is 30 degree. If I am nearer, elevation angle increases. If I am going, elevation angle decreases. Now what happens? This handle will touch the body of the patient. It will overshoot like that. It will hit it like this. आप कर रहे हैं surgery, it overshoots. Outside I am moving 2 centimeters, inside it go 10 centimeters. I can perforate the iliac vessel. It can perforate the bowel. It can perforate the sigmoid colon. You are separating the gallbladder, it hit the diaphragm. Patient has pneumothorax. Happens a lot. Why? Problem is your port is making, your instrument is making class 3 lever. You have not intended to do that. Your port is wrong. I have showed you this video and you have seen it before, and I have shown you that this is a wrong port position, and you can see here surgeon is holding the needle, and see this port. Here 2/3 of the needle holder is inside the abdomen. Do you know this needle holder is coming from the lumbar region? That is bad. Half instrument should be in. Here more than 2/3 instrument is in. Another mistake what he is doing, holding that needle, and third, taking a wrap by the left hand. Wrap by the left hand like this here. Can you see that? And then this instrument is more than 80% inside the abdomen, and he was not intended to see that much instrument. So he was not intended to do that, but his instrument has got class 3 lever. It has punctured the iliac vessel, and this is huge hematoma forming. Do you know it will not going not to stop. तो इसको तुरंत ओपन करना पड़ेगा. You have to open it and do it. So problem is what? Problem is class 3 lever. Class 3 lever. So always your instrument should make class 1 lever. Always class 1 lever. For that what to do? First you should try to find out the target. Where is the target? What is target? Target is the most crucial part of dissection. Like in myomectomy, fundus of the myoma is not target, base of the myoma. In appendectomy, base of the appendix. In ovarian cystectomy, center of the cyst. Not the, because ultimately you will aspirate, and when you do enucleation, center. But in salpingo-oophorectomy, your target is not the center of the cyst, it is IP ligament. In hysterectomy, target is not the round ligament, uterine artery is the target. You got it? Because most attention you are giving at that point, because maximum ureteric injury happen during uterine coagulation. If bleeding doesn't stop and laterally you are going. So target is not the part which is inaccessible. Target is the most risky part, most crucial part of surgery. After that you will try to find out the length of your instrument. As we know, normal adult instrument is 36 centimeter, senior pediatric 28 centimeter, junior pediatric 20 centimeter, and bariatric 45 centimeter. Then you will draw 2 arcs keeping the target in the center, 18 and 24. Why 18? Because 18 is the half of the instrument and 24 is 2/3. And then you keep the telescope over the 24 and instrument at 18. Telescope ideally should be put 24, not 18. However, 18 also can be used, but 24 is appreciated. Why 18? Why 18? Because it is half of the length of your instrument. And why 24? Because 24 is 2/3 of the instrument, and ideally telescope should be 24. However, it can be 18 to 24. But in advanced surgery, it is better to have 24. Now tell me that why 24 is better. for telescope. Why not 18? And even if you keep the telescope at 24 centimeter, telescope is making class 1 lever. How?
10 centimeter is focal length.
Yes. So this is very important that telescope can never work if it touch the tissue. Am I right? Touch the tissue. Because if telescope, if I will touch my eye to something, can I see that object? I must need to keep it at focal length to see carefully. Am I right? So that's why telescope, if you will keep it 18 and you will remove it out, it will make which lever? Type 2, class 2 lever it will become. Am I right? But if you will keep at 24 and then take it out, this class 3 will become class 1. You got it? Because you need a distance, so half in and half out will be there even if you keep at 24. So that is important to understand, because simple physics, it's not a rocket science, very simple physics, optics, very simple. So these are the 3 laws: half instrument in, half instrument out, telescope in the middle, and manipulation angle ideally should be as near as possible to the 60 degree. And that is like a field of a baseball and or a field of a diamond. This is a baseball. Baseball is not a very popular game in India, but it is very popular in Europe. This is baseball. And you can see here, this is the home position, position of first player, position of second player, position of third player. So this will be your target. This is 18, this is 18, this is 18, and this is 24. So telescope can be anywhere in between 18 and 24. Ideally 24 should be appreciated for advanced surgery, and instrument is 18, and this is your one arc, this is 18, this arc, and this arc is 24, and manipulation angle is 60 degree. As we have discussed the first day, that whatever we do in our day-to-day life, we have a better ergonomics if our manipulation angle is 60 degree. 60 degree manipulation angle is ideal for every surgery which you do in day-to-day life, advanced surgery especially, and organ target is fixed especially. In gynae you have a liberty. In gynae you have a liberty that your target can be brought to the midline by uterine manipulator. So by this, cut this, and then cut this, uterus itself moves. But suppose fundoplication we cannot move. Nephrectomy never. In splenectomy not possible. So in those situations manipulation angle is fixed, and that should be according to target. So let us take few examples. This is example of very small ovarian cyst, and suppose this is the right side of the left side of the ovarian cyst, and it is fixed, adhered with the ovarian fossa, suppose endometrioma, ovarian fossa, but it is a small, not very big. So this is one arc, this is another arc. Telescope will be in umbilicus, and one port 7.5 centimeter lateral this side, another port 7.5 centimeter lateral that side, telescope in the center, and ideally gynecologist should stand near the opposite shoulder. Ideally, if you are doing left side, you should go near the right side. Always in laparoscopy, surgeons should stand opposite to the pathology. Nobody can perform appendectomy standing to the right. Nobody can perform right hernia standing to the right. You must go opposite to the pathology, then only you can perform the surgery. And this should be 7.5 centimeter lateral this side, 7.5 this. Why 7.5? Why not 8 or 9? Because as long as your instrument is 36, you have to stand 7.5. So that distance between two ports should be 15 centimeter. For that you should understand the principle of 4 triangle. Here I am making 4 triangle. This is triangle number 1. This is triangle number 2. This is triangle number 3. and this is triangle number 4. So I have made 4 triangles here. This is 45 centimeter instrument, 45 centimeter. This is 36 centimeter instrument. This is 28 centimeter instrument, and this is 20 centimeter instrument. And this is bariatric, this is adult, this is senior pediatric, and this is junior pediatric, right? And see here, this is umbilicus, this is umbilicus. What is the length of the junior pediatric instrument? 20. How much should be in, how much should be out? 10 centimeter. See, only this is 10 centimeter in and 10 centimeter will be out, like that. And this is abdomen. In junior pediatric instrument, from umbilicus either side you should be only 3 centimeter. In senior pediatric, 5 centimeter. In adult, 7.5, and in bariatric, 10. And see, this angle is same for all. So how much you will go away from midline depending upon not the body of the patient, depending upon size of your instrument. If you will try to make a triangle of a matchstick, a triangle of 3 matchstick, only few millimeter it will go either side. Same triangle, if you will make a straw of a cold drink, three straw, it will go many centimeter away. And then also manipulation angle will be 60 degree. If you will make a same triangle with the billiard stick, long one, many feet away. And if you will make same triangle with a big bamboo, it will be many meter away. But still triangle manipulation angle will be 60 degree. So suppose you have a 45 centimeter instrument, this one, and if I will keep it just like pediatric 3 centimeter either side, will it make a 60 degree angle? Never. See, it is making 10 degree angle. Manipulation angle means angle between 2 working instruments. And if it is a pediatric instrument, that much small, and I will keep it 10 centimeter either side apart, means in between 2, then will it make 60 degree? Never. So which is more important? Manipulation, which is more important? Size of the body or size of the patient, or size of the instrument? Size of the instrument. So that's why it doesn't matter patient is obese, patient is small, patient is big, patient is tall, patient is dwarf. As long as you are using 36 centimeter instrument, you must go 18 centimeter from the target, and in between 2 working instrument distance should be 15 centimeter. Then only you will get a 60 degree manipulation angle. Let us take few real case example. Suppose you have a small girl, इतनी छोटी लड़की है आपके पास, and here is the uterus. The small girl uterus is like a tubular uterus, ऐसा ही uterus होता है, and she has a dermoid cyst like 6 centimeter, and this ovary is okay, small, and here is the umbilicus, here is the GP sternum, and you don't have junior pediatric instrument. You have senior pediatric instrument, 28 centimeter. But junior pediatric you don't have because you don't do the surgery of less than 5 years. So you don't have why to spend money, you don't have. But you want to do the surgery. Tell me where should be the port? Pardon? कहाँ पोर्ट लगाएंगे बताइए? Where will be the port? I will show you. One port should be palmar, one port GP and one port lumbar. Because here this is the target, suppose this is the target, then this arc will be 14. Why 14 is the half of the 28 centimeter, and this is 18. So this is telescope, and this is one instrument, this is another instrument, and then you will perform surgery, and your baseball diamond concept will be done. It will make a shape of diamond. See, can you see the diamond? This is not the diamond which you are wearing. This is diamond, Kohinoor wala diamond. This is diamond, and this is called diamond shape. If you don't follow it, and if you put the port here, one port here, and one port here, and one port here, just reading the book, then you can perform surgery, but only by cannula, not by the instrument. Because your instrument will not come out of the cannula also. वो घुसेगा ही नहीं अंदर. It will touch the target. And so I will show you real video. Real video of a oophorectomy in children. Let us see. This is a 3-year-old girl, and she has a bony component in her dermoid cyst. Bone था उसमें, so you can, and multiple dermoid, not one. So you cannot do the cystectomy. And see, her abdomen is so small. एकदम छोटा सा abdomen है. That much a small abdomen. So this is a small abdomen, and only 28 centimeter instrument is used here. This is entry with the palmar. Veress needle will go to the palmar, irrigation suction hanging drop you can do, and you will enter. Trocar also will, and here rate of gas of the entry will be 0.3 liter per minute. See here, this is pediatric mode. Can you see that? What is the mode? क्या लिखा हुआ है यहाँ? Pediatric. What is actual pressure? What is the preset pressure? 8. What is flow rate? 0.3, because 3 years. And what should be total amount? 3 into 2, 600. देखिए 0.6 में इसका हो गया. Only 0.6 में this 8 is reached. You got it? So this is enough. 0.3 में it came. So into 2 into age, into 100. 2 into age means not 6 ml, it will not become 600 ml. 2 into age in pediatric. You cannot expect minimum 1.5. And now you will trocar. See trocar how it is introduced. By stretching, and trocar is introduced. After that you have the other instrument, and here we are in. Now you can see this is the left ovary. Left ovary is fine. This is the ureter of the left side. Below the IP ligament, left ovary is okay. Sigmoid is distended. This is sigmoid. This is right ovary. Multiple ovarian dermoid you can see. And it is bony component is inside. And here is the uterus. Uterus is undeveloped, just like a tubular uterus will be there. And check this instrument, do you know it is coming from epigastric. If you will extrapolate, you can extrapolate करेंगे, line को ऐसे ऐसे बढ़ाएंगे, तो you will be able to imagine that from where this port might be coming. So it is coming from GP sternum, just like in college cystectomy, how we put the port GP sternum. And this is coming from lumbar. Did you see that? And see what is manipulation angle? 60. Both the instrument angle is 60, and it is doing oophorectomy. You have to protect the tube. So it is holding the, and this is major ovarian, and IO ligament, infundibular ovarian, and then major ovarian. So slowly, it is separating, and now this is last part, and ovary is out. Tube was not damaged. This is tube. It is out, and out. After that, you will use one endovag. This is tube. Tube is fine. Tube is okay. Now there is an endo bag, and now this endo bag is coming from Palmer's point, because only Palmer you have 10 mm. This is Palmer and this is lumbar. So it is holding like that, and then right now telescope is in epigastric, 5 mm telescope. That's why field of vision is small, 5 mm telescope. And now this is the endo bag. Endo bag is must in dermoid, and it is closing the endo bag, and now it will be taken out through the Palmer's point, and it is coming here, and see there, see this distance is here will be 5 centimeter only because it's senior pediatric, and this is 5 centimeter distance this side, 5 centimeter distance that side, and it is making a shape of diamond. This is like that, like that, like that, like that, and this is bone, and the hair is coming from Palmer's point, and this is how you will perform the surgery. So if you will put in the umbilicus, you can never perform the surgery. And here this is 5 centimeter this side, 5 centimeter that side. This is one epigastric, this is lumbar, and this is Palmer's, this is Palmer's. So one port here, one port here, one port here. So basically, and now it is, assistant will hold it like that, and you will break all this bone and nail and the hair and tooth, all has come out from this dermoid, and it is done, surgery over. So this way, baseball diamond concept has to follow regardless of the surgery you want to do. And this principle of 4 triangle you have to follow. Another example, here we can see this is appendectomy. In appendix, the target is not the appendix, target is the base of the appendix. So this is the target. Telescope here may be in the umbilicus, one port suprapubic, one port right hypochondrium. And if you will put one port here, and one port here, and one port here, your instrument will make class 3 liver. That's why you might have seen on Saturday after hysterectomy, when I was doing appendectomy, I was struggling, because appendix reached somehow up to here, am I right? And I was holding with this instrument. Did you see that? So it was making which class of liver? Class 3. So ideally I would have changed the telescope. But you know, if you know that you are working with class 3 liver, but just to help the patient not making extra port, I am ready to struggle, then it is allowed. But if you don't know that you are doing wrong, and then you are doing, it is not allowed. Just like you have a good driving sense, but you are in good mood, and you increase little bit accelerator and you are overtaking another car, your inside consciousness always will say, yaar kya kar rahe ho, tum maroge kya kar rahe ho, don't do that, don't do that. Am I right? And you will be very careful, because you know that you are doing wrong. But if you are drunken and you are not doing wrong, accident is waiting to happen. So similarly, sometimes we avoid the ergonomics just to give cosmetic advantage to the patient. But if you see that safety is going more important than ergonomics, I am now about to do the accident, then you must change the port. But you will change the port only you know where has to be the correct port. So suppose appendix is going like that, this direction, one port should be here, one should be here, and then only it will make a shape of the baseball diamond. If it is going subhepatic, different appendic port will be different. Again, another example, that this is a small uterus and LAVH is formed. Hysterectomy just by LAVH. This arc is 18, this arc is 24. In LAVH, you never need supraumbilical port. Do you know why? You have to take only upper pedicle, uterine artery will be taken from below. Colpotomy will be done from below. So you never need cranial traction. You don't need, only you have to take round ligament, fallopian tube, ovarian ligament. Am I right? And for that, cranial traction is not allowed. So this is enough. But suppose you are making a very large port, large uterus, then you have to make different way. Do you know That mean that we should go in the operation theater with some sketch pen, some compass, and some scale. Ideally, we should go in the operation theater with the surgical sketch pens. These are available in the market, very cheap and made up of indigo caramine and methylene blue dye. And it is available everywhere in Amazon, eBay, everywhere. Surgical sketch pen you can buy. These are available, and it is very cheap. These pens are there, and you can keep it in the pre-sterilized already. It is available. This is pre-sterilized and gamma radiated surgical skin body pain marker. It is available, and these pen has methylene blue and indigo caramine dye, and you can use for marking on the abdomen. Advantage of these pens that you can keep it in the form. Mostly it is done by cosmetic surgeon, plastic surgeon, because for them even 1 millimeter is important. But for us also we should try to use it, and you should draw. If it is not there, then what to do? You should draw with a hand. You should make a shape of a diamond. This is diamond. And then keep the telescope, thumb over the telescope and index finger over the target. And then one snuff box will give you one port, another snuff box. This is a snuff box. So distance between the index finger to this snuff box is mostly 18 centimeter in the man. In the woman, it comes up to a steroid process. So today, once you go home, find out a scale and measure that where is your 18 centimeter. From index finger, mostly it will come here. For the ladies, did you see? And in the man, this is a snuff box which come 18 centimeter. And I am sure that you cannot forget your body. If otherwise, you can ask a tattoo here to remember 18 centimeter. And then you make a shape of diamond like this. And thumb is your telescope, index finger is your target. How you will know target? Remember, target always decided after putting telescope inside, never from outside. And once your telescope is inside, this is the telescope, and telescope is inside, then suppose this is the target, this is appendix. तो आराम से टेलीस्कोप को ले जाएं and touch it nearer the base, and then touch the anterior abdominal wall, ऐसे, tip of the telescope, and you will see trans illumination also. I'm going to show you in the lab today baseball, and touch the trans illumination also. After that, put the index finger over the target and thumb over the umbilicus. And one snuff box is one port, another snuff box is another port. It's very easy, very easy. So you will make, suppose this is a large uterus, very large uterus. This uterus is coming in between umbilicus and pubic symphysis. It is here, uterus is up to here. So thumb will be your telescope, and these two snuff boxes, 2 port. And this is telescope, and one port is here, another port is there. And this manipulation angle is 60 degree. But there is a problem. Problem is that with these 3 ports, you can do only upper pedicle. If you will go to vault closure or uterine artery with this port, then it will make which class of liver? 3, yes. So you need another 2 ports, ek yahan and ek yahan. So do you know, in very large uterus, you have to make 5 ports, and your entry has to be with the palmars, because very high epigastric port you cannot put blindly. Little bit supraumbilical will work, but very big will not work. So that's why you have to use palmar's point for those ports. Like we can see here, this is a large uterus. This patient uterus is large, palpable up to here, huge fibroid. So entry, this is Mishra's point, this is Palmer's point. So this is, you will put the Palmer's or Mishra's point, you will put Veress needle, and then you will put epigastric, यहाँ पे GP sternum है up to here, so you will put the port here, but directly you will put it, you will tear the liver. And you know, in the very large uterus, you need bilateral to two port this side, two port that side. And for other pedicle, you have to walk over to the other side. So total 5 port is required in this. Right now telescope is in Palmer's, but under vision Palmer, this is epigastric port. Under vision of Palmer, directly I can puncture transverse colon, I can puncture the gallbladder, I can puncture the liver, and then you will put, and then you will transfer telescope from here to there. And after that again you will make the port, 1 port down, and then 2 port this side. Total 5 port is required for large uterus. That is called bilateral ipsilateral port. And now telescope is going epigastric like that. And now again you will make 1 port here. So for large uterus you cannot do by 3 port or 4 port. Sometimes 5 or 6 port is required to perform the surgery. मतलब 2 यहाँ और फिर 2 यहाँ भी हो सकता है बने आदमी. 3 port either side according to the size. And see, this is now 3rd port it is, and then 2 port you will go other side. So it is very important that in the large uterus you have to put Palmer entry first, and then 2 for upper pedicle, 2 for lower pedicle. Again another example, that suppose you have left-sided inguinal hernia. The hernia surgery, this bulge of the hernia is not the target. Target is our deep ring. So keeping the deep ring, because we have to put mesh here. You will draw 2 arcs, 18 and 24 centimeter. Telescope can be anywhere in between 18 and 24. Because it is not directly touching, so as far as you can respect the umbilicus, it will be appreciated. And then this is the right hand and this is the left hand, and surgeons must stand near the opposite shoulder, and monitor should be placed here, so that you will have a coaxial alignment. Eye of the surgeon, target of dissection and center of the monitor should be in the same axis. That is called coaxial alignment. Again another example, right side of hernia. This is again telescope in umbilicus, 1 port 7.5 centimeter right, other port 7.5 centimeter left. Telescope in the center and manipulation angle is 60 degree. So you have to stand here, surgeon will stand here, monitor will be here, and this is the telescope, this will be one hand, this will be another hand, like that, and you will perform surgery. Next example is that if you have fundoplication. In fundoplication your target is high up, almost near angle of his, because you are doing mobilization, retroesophageal tunnel, and then wrap and suturing. Most of the suturing will be done in the upper abdomen. So you must need supraumbilical port. If you will go in the umbilicus during mobilization of esophagus from the posterior mediastinum, you will struggle, because your vision will struggle, you will not be, and your all the instruments should make baseball, one right hypochondrium, one left hypochondrium, and ideally you should stand in between the leg. Like for Heller's myotomy, hiatus hernia, standing in between the leg is preferred, and monitor should be near both the shoulder, and anesthetist has to be in the middle. And this is how you will do for upper abdominal surgery. You know, everybody follows baseball, but if you will ask your professor why you are putting sir port here, he will say it is good there. You will say why it is good, I am telling you it is very good. But why it is good? Then they will say, I am telling you, don't argue, everybody does here. And this is the problem, that because everybody does here, I should put here, it is good. But if pathology is a little bit variated, then also I will put there only. Am I right? And then I will struggle. I have seen many senior gynecologists, वो एक बार रट्टा मार लेते हैं वहीं पर पोर्ट हर एक यूट्रस में. Every uterus they put the port there only, and then they struggle because every ovarian cyst of 4 centimeter and 14 centimeter has no similarity in port position. A fibroid of 4 centimeter and 14 centimeter, unparalleled. Ground and sky is completely different port position. Every patient need different port position. So same is bariatric. Telescope is supraumbilical, one right hypochondrium, one left hypochondrium, and these are the basic port. Now question is where to put if I have to put the third or fourth port. That should be again 7.5 centimeter lateral to the nearest port. So this is basic 3 port. Now there are few exceptions. That exception I would like to discuss. Few exceptions are also there which we should keep in mind. Suppose you are doing duodenal perforation. Here is the patient. This is esophagus. This is stomach. And here is perforated duodenum. This is 18, this is 24. I am putting telescope here, putting one port here, putting one port here. And this is good. This is a shape of a diamond ban gaya. This is diamond shape. Am I right? So this is a shape of a diamond. It is good. And now I am standing in between the leg. This is telescope. This is telescope. And this is my one hand. And this is other hand. And ideally you should stand here. Monitor should be here. This is monitor. But suppose due to any reason, I don't want to stand here, surgeon doesn't want to stand here. Due to any reason, probably the reason may be that your table cannot steer up position. Steer up position means leg apart without lithotomy. Or your monitor cannot go to the head because it is fixed somewhere by pendant or anesthetist, or your Boyle's apparatus doesn't have that much tube of supply of oxygen. बहुत सारा problem हो जाता है. You cannot go to the in between leg. And you want to stand here because your monitor is fixed here. Many people, they don't use trolley like monitor. They make a cupboard and they put the monitor in the glass cover. That is very bad because you are suffocating your monitor. It will spoil. You need completely open environment. So this is one to do. Because my anesthetist cannot move, Boyle apparatus has pendant, oxygen pipeline, many problems are there. Now in this situation, your hand cannot reach. You need a hand of a ghost to elongate to reach there. This you can hold, but ये कैसे इतना लंबा कैसे करेंगे हाथ को? You don't have a hand extended. Otherwise, you have to bend like that, and you have to tendency to fall over the patient. Very bad. So there is a liberty. Liberty is that you bring this port here and bring this port here. And if you will see now that this angle is here and this is here. And still your manipulation angle is 60. And this is 15 and this is how much? 45, yes. And this is called azimuth angle. Azimuth angle. Azimuth angle can vary in between 14 and 45. So 15 and 45. Azimuth angle is very good. I will show you that it should be always variable according to the variation of azimuth angle. Azimuth angle is angle between the telescope and one instrument. This is azimuth angle, this. Ideally it should be 30 degree either side. But because of any reason इसको हम घटा रहे हैं ऐसे, then other side it should be increased. You got it? Ideally 30 degree azimuth, but suppose I have to put, suppose inferior epigastric is coming and I have to decrease it. So here I am going medial to inferior epigastric, then other side I should go lateral to inferior epigastric. So this is how much? 45. But remember, this is if 45, then this should be 15 as it. And remember, azimuth angle should never be more than 90. If it is more than 90, it gives you mirror image. Mirror image means the reverse view. Right will start moving left, left will start moving right, and you will be crying during surgery. So this is called azimuth angle. This azimuth angle right now is 15 and this is 45. This is what we do in cholecystectomy. In cholecystectomy, how it works, I will tell you. This is the gallbladder, this is the patient, and here is the diaphragm, और यहाँ पे ऐसे करके this is the gallbladder. Once we push the gallbladder towards the diaphragm, gallbladder goes like that, and this is our target. Target is not the fundus. Now Americans, how they do, they put one port here, एक यहाँ और एक यहाँ. This is their port position, and they, sorry, American not, French, and this is the French position of the cholecystectomy. They put it like this, and there both the azimuth angle is 30-30, and surgeon stand and monitor. This is called French position of cholecystectomy. One assistant here, second assistant here, and they have a very good manipulation angle 60 degree, azimuth angle 30-30. But American, what we do, we put port here. So this is increased like that, and this is here in the mid clavicular line. So this is like this, and we stand here. We never stand in between the leg. So this is the American position. One azimuth angle is 15, another is 45. So azimuth angle can vary from 15 to 45. And what is the rule of the fourth position, fourth port? If there is any fourth port required, that should be 7.5 centimeter lateral to the nearest port. So what we are using here, we are putting the port for the fourth port to hold the fundus. So that should be 7.5 centimeter nearer to the fourth. Now what to do in nephrectomy? In nephrectomy also, telescope should be 10 centimeter lateral to the umbilicus. Here you cannot put the telescope in the umbilicus, otherwise all the bowel will drop here. So telescope should be in the mid-clavicular line. This is the mid-clavicular line. One port 7.5 here, another port 7.5. You know, in this picture it looks like we are too near, but actually not, because kidney is not in the abdomen. Kidney is a retroperitoneal organ. So we are not here can imagine the depth, because it is a two-dimensional picture here. Am I right? So if target is here, in kidney target is here, not in the abdomen. So if you will measure, one port will be mid-clavicular line here, one port up, one port down. And because kidney hilum is retroperitoneal, not in the abdomen. So you have to fly over to the colon, and then you need cauterization. So one port here in the mid-clavicular line, and one port here, and this is how you can, and the table should bend 140 degree, 140 degree kidney bridge position. And in transperitoneal nephrectomy, you have to stand in front of the patient. So baseball diamond concept is everywhere. It is not like that it is dependent upon the surgery. Everybody, not on the specialization. It doesn't matter you are surgeon, you are gynecologist, you are urologist. Basic principle of laparoscopy is same. Access technique is same, dissection technique is same, approximation technique is same. Only your organs are different. Again coming back, if suppose you have a umbilicus itself is diseased, then you have to draw two arcs keeping the target in the center, and this is 18 and this is 24. This is 18, one arc, and then 24, another arc. And then entry will be with the palmer's point. And after that 7.5, 7.5. If you are performing by 3 port, then after entry to the palmar, you may transfer the telescope to the midline and then use palmar for your right hand. So this will be your, but First you enter in palmar and then under vision you put other ports and then transfer the telescope to the midline, and this is how you will stand, and this is your manipulation angle 60 degree. Surgeon will stand here, monitor should be placed here, and this way you can remove all the adhesion. Then you put a mesh either by transfacial fixation and then apply trocars. Again, question is why to keep telescope in the center? Why to keep telescope in the center? You know, in laparoscopy, we don't have binocular vision. We have monocular vision. Binocular vision means 3D. However, 3D laparoscope was introduced, but it is flop. Why it is flop? I will show you during robotic lecture on 17th, because it will take time to discuss why 3D laparoscopy is not a success. That I will discuss later. So normal our laparoscopic camera, those are 2D, and we have a monocular vision. We don't have a binocular vision. For see the depth, we need binocular vision. Only few animals are lucky that we have a binocular vision. Many of the primitive animals, they cannot see 3D, like fish. Fish can never see 3D, because in fish, one eye is at this corner, another eye is at this corner. So from half of the eye they see one world, from half of the eye they see another world. To see 3D, you have to see same object in both the eye. That's why it is called what? A stereoscopic vision. Am I right? Same object in both eye, then only you can see 3D. I will show you. I will demonstrate you, don't worry. Any of you, चलिए आप में से कोई भी आदमी मेरे पास आ जाइए. You come here, come. Any of you come. Come. Anyone come. I have a two object here in my hand. Please come. And come this side. Open your specs. Okay, keep specs, no problem. Now I have a two thing here. Close one of your eye and see the tip of this canal trocar. Tell me which is nearer to you. No, guess.
Right.
See, he is doing wrong. You think this is nearer? This is away. Anybody else come? With both the eye you will see that it is. Now close the eye again. And which one is nearer? This one.
Right.
Open the eye. Now you see. Which one was nearer to you? This one. You can never judge the depth with one eye. Is it clear? You cannot. You can. Thank you. You can repeat this at your home. Take two pencils and tell anyone to close the eye and see the tip of the pencil. Tell me which is nearer. He will never tell you correct. वो आपको वो ऐसे हाथ से तो पता चल जाता है ये मेरा ही हाथ है. So this is fraud. But other से नहीं होगा. It will not happen. This is a normal experiment which optics is written also. So two eyes should see same object. So fish doesn't have 3D. And once evolution has started, slowly, you know, during the process of evolution, dimensions were added in the animal. So dimensions like, you know, plant has no dimension, it cannot move. So they are in zero dimension, they don't have sensory organ, they don't have nervous system, तो उसको dimension है ही नहीं. Then the very primitive amoebas, they were moving in single dimension. For them, two dimension is also doesn't exist. Either they only walk on the surface. After that, fishes and all, they have two dimension. Then slowly, horse and buffalo, they have 2.5 dimension. Why? Their half of the horse, they see same object in both eye. And other half of the eye, they see different object. That's why horse rider in the town, they cover half of the eye of the horse. So they force the horse to see the same object in both the eye. Then horse get 3D. And then it will not hit another object. It is not like that they will be afraid and that's why. If they will be afraid, that they can see the afraid in front also. They force the eye that don't see different object in different eye. Because their one eye is at this corner. You see horse or cow, one eye at this corner, other eye at this corner. So they half of the eye they have 3D and other half they have 2D. So they covered it like that. So only they see 3D. 2D they cannot see. But chimpanzee and human, we have a real 3D because our both the eye is in front. Fish, one eye is here, one eye is here. They have one advantage. Their field of vision is 360. So if some big fish is coming from behind, they can see that. And they will swim away, which we cannot see. Our enemies are laughing behind us. We don't have any idea that what they are laughing or hitting. This is the problem. So, question is, if we don't have this 3D, then how we are surviving? We are surviving with our depth cue. Depth cue means hint about depth. One of the depth cue is occlusion. Occlusion means if I am occluding this wall, my body is occluding this wall, then which is nearer to you? Me or this wall? Me. This is common sense. If this podium is occluding my body, which is nearer to you? Podium. If you are occluding chair, then it is true that chair is not sitting on you. You are sitting on the chair. So exactly same way, there are many depth cue. One is occlusion, other is relative size. Relative size means all of you which is in the last seat, your face looks small to me. All of you see in the front, they are looking big. But are they really big? They are not big. Because of depth, it looks like big. Another is aerial gradient. All of you which is in the back seat, your face is not clear. Front, everybody face is clear. This is called aerial gradient. After that, fogging also gives you depth perception. Then you have linear parallax. See this pillar here, this pillar. See this pillar. With increasing depth, both these lines are meeting each other. Can you see that? This is called linear parallax. Just like you stand in between a railway line, you will see both the lines are meeting. But are they really meeting? What is this? Depth cue. Hint about the depth. If they are meeting, that means it is deeper. So this all we have in laparoscopy. But remember, again texture gradient. Texture gradient means brighter texture means nearer to you. Darker texture means away from you. This is bright because it is elevated. This gives you depth perception. This is bright, that means elevated. This is dark, that means deeper. Am I right? So after that, you have these all depth cue and shadow. Shadow also gives you depth cue. So these all depth cues are only good if telescope is in the center. If you stand by the, suppose railway line is going like that and I will stand by the side of railway line, not go in between railway line, can I see linear parallax? No. Motion parallax is, this is motion parallax. If I move nearer to camera, it looks move more. If I move away from the camera, it will, a bowel loop which is nearer to the telescope moves more. Bowel loop away from the telescope look like moving less. This is called motion parallax. But these all are only possible if the telescope is in the center. That's why ideally telescope should be in the center of the working instrument. All the advanced surgery telescopes should be in the center of working instrument so that you have a better depth cue. Stereoscopic depth cue, because depth perception, real binocular vision, we don't have in laparoscopy. So this is what you should do. Now what to do if you have a two target? Laparoscopy is the answer of the two target also. Like suppose you have to do bilateral. Suppose here we have to do hemicolectomy. Hemicolectomy we have to do, and one target is splenic flexor of colon, other target is rectum. And this is a pediatric patient. So what will be the arc? 14 and 16, here again 14. And see, automatically you will get a two common cutting area. And in these two common cutting area, you can put the port. and you can do bilateral surgery or two surgeries. Whenever you have to perform this will be your port position. Telescope in the center, surgeon will stand here, monitor will be here. And once this area dissection is over, you have to come to the rectum. Then telescope will go here, and same port you can do, and surgeon will go here, monitor will go here. So baseball can give you the answer even if you have a bilateral surgery. Like suppose this is a bilateral hernia surgery, and this is one hernia and this is another hernia, two side hernia. And then baseball will give you answer for bilateral hernia as well. And you can draw the port position. And you see both the arcs are cutting at common area. This is the arc for left side, this is the arc for right side, and both are cutting common area, and your port will be where the area is common. So one port will be here, other port will be here, and all the three port is in the same line. And then only by the three port you can perform bilateral surgery. So this is the real wound of bilateral surgery. So baseball can not only give you the port position for one surgery, even if you have a two or three surgery, it will give you a common cutting area where both the arcs are cutting each other. So I will like to explain it little more. Like let us consider, sorry, opening something else. Let us consider that you have patient. This is the patient, and this is one hernia. Not only hernia, salpingoplectomy or lymphadenectomy for radical hysterectomy or varicocelectomy for surgeon is same port. So suppose this is one target, this is other target, and this is the one arc, this is the second arc, and you are putting telescope here, one port here, one port here. You are very, very happy, as this is your telescope here, and this is your one instrument, and this is your another instrument. Am I right? And it is satisfying. You are standing here, and you are satisfying baseball. Very good. But tell me, by these three ports, 1, 2, 3, can you perform this hernia? It will be very styling. This instrument will make which class of lever? Class 3. Am I right? This instrument. This instrument will be which class of lever? Class 2. And your manipulation angle will be 10 degree. How can you perform? This port position is not for appropriate for this side. So baseball diamond concept is saying that don't do like this. See, ideally, suppose this is the target, and if you have a bilateral surgery, then one port here, one port here, one port here, one port here. Am I right? These three for which side? Left side. And these three for which side? Right side. What is the distance between these two working instruments? 15 centimeter. Am I right? And what is this instrument, working instrument? 15 centimeter. So total how many port? 5 port. So patient will not be happy. यार क्या कर दिया? सब जगह port ही बना दिया. Telescope is here, and these are 5 ports. So baseball is saying, don't do that. We both will be compromised. You go little up, and you also go little up, and this also you go little down, and you also go little down. So basically it is a compromise of and these are the 3 ports in the same line. So baseball diamond concept is giving you the port position like that. And this is very important that in bilateral surgery, 2 common cutting area where both the arcs are crossing each other is the port position. So I will show you. Again, same way, it is not only for bilateral hernia, bilateral salpingoplectomy, bilateral ovarian cystectomy, bilateral lymphadenectomy in radical hysterectomy, bilateral orchidopexy, bilateral varicocelectomy. Because only your specialization is changed, target is not changed. See here, this is the real port position if you have the bilateral surgery. This is for which side? Right side. This is for which side? Left side, and this is for bilateral. So baseball diamond concept, if you will do right side and then you do left side, not possible. If you have a left side port and want to do for right side, not possible. you will cry. So common cutting area, and even in bilateral surgery you can perform with the same port. So baseball diamond concept is giving you answer for multiple port also. Let us take one example, colorectal surgery. Do you know in colorectal surgery we have to take 6, 7, sometime 8 and 9 ports also, and all is following the baseball diamond concept. See here, this is surgery of low anterior resection. Those many ports are there. Do you know why? When you have to do, even if you want to remove 5 centimeters of the colon, entire half of the colon has to mobilize. Because colon cannot be pulled and anastomosed because it is fixed with the paracolic gutter. So, if you have to do transverse colon, telescope will be here and these 2 ports will work. And you will be standing where? In between the leg. Am I right? In between the leg. When you have to do a splenic flexor of colon, telescope will be like this and these 2 ports will work. What is manipulation angle? 60. When you are doing descending colon, telescope will be here and these 2 ports will work. When you have to do rectum, you will go near the head, telescope will be here and these 2 ports will work. When you have to do sigmoid colon, telescope will be here and these 2 ports will work. Tell me anywhere is not 60 degree, everywhere 60 degree. Starting from transverse colon up to rectum, everywhere it is 60 degree. But you have to use multiple ports. Then only you can efficiently, ergonomically, comfortably you can perform the surgery. So it doesn't matter what is your specialization, your manipulation angle need to be 60 degree, your azimuth angle better to have 30-30 and you can do that. Now this is called contralateral port position. Contralateral port position has one disadvantage. Disadvantage is that your camera person hand come in between your arm and body. So this is arm and body. If both is male, it is okay. If she is female and this is male, she will hit you. They never want that someone should touch the body. So gynecologists, female gynecologists, they hate this port position because camera person hand is touching their body. And another privilege what they have, that their organs are mobile. Organs are mobile. So I can move my target. When I have to use this uterine artery, uterus will become like this, cut this. And once you did it, uterus will become like that, cut this. Hernia will not come right to midline that cut this and left to midline to cut this. But thanks to uterus, this has a contralateral variation, 9 o'clock, 3 o'clock. If it doesn't move, you will struggle. Otherwise, it is comfortable. So this is the privilege what gynecologist has, and they love ipsilateral port position. What is ipsilateral port position? One azimuth angle will be 30, other will be 60. However, they also follow baseball. They are also half instrument in, half instrument out. But telescope is not in the middle. Telescope is in one sector and instruments are other sectors. So if you see carefully, suppose this is the target, then here also distance from the target, this is target, distance from the target to this instrument is 18, this is also 18 and this is 24. This is 24. So what is the difference? Difference is that this is telescope, this is one instrument and this is another instrument. So one azimuth angle is 30 and another azimuth angle is 60. If suppose I would have put the telescope here, then this also is contralateral port position. Am I right? But I don't want it. What is the advantage? That surgeon has freedom of movement. Another, your arm is fully adducted. In contralateral port position, your arm will be little abducted. 10 degree abduction is must. 10 degree ऐसे करना पड़ेगा. But in ipsilateral, your manipulation angle is 30, so arm is fully touching. So if you will see that suppose this is one instrument, this is another instrument, देखिए थोड़ा सा हाथ ऐसे हो जाएगा. But ipsilateral you will be performing. And ladies, they don't do exercises, they should must join the gym if they want to do laparoscopy, but if they are not going to gym, their deltoid is not strong. And if they have pain in the deltoid. Many of you might be feeling pain in the lab while you are doing. So that's why ipsilateral is preferred, but it is only for the mobile uterus. And however, in that also, one contralateral is good, because if this side of uterine, suppose uterine of this side, you want to take from other side, you have a injury chances of ureter. As so for doing colpotomy of right side, one right port is better. For taking uterine right side, right port is better. So it is a mixture of ipsilateral and contralateral port position. In ipsilateral, difference is sectorization. Sectorization means telescope in one sector, instrument is in another sector. That is called ipsilateral port position. Now tap block. Many a time in daycare hospital, you can offer the patient tap block. This is costal margin, this is iliac crest, and this is the mid axillary line here. In between costal margin and iliac crest, you will, under ultrasound guided, you can put a spinal needle and you can inject some bupivacaine or lignocaine in the transversus abdominis plane. We can see here all the planes are visible, and these planes are good to do. This is a skin here, this is a skin, this is external oblique muscle, this is internal oblique muscle, and this is transversus abdominis muscle. We have to inject our local anesthetics in this transversus abdominis muscle here, not preperitoneal, not in the abdomen, because all the nerves of the sensory of the abdominal wall come at this plane. So here you will put the needle, and you can see here needle is coming, this is the needle, and then ask the assistant to attach the syringe, and you can see blabbing here, it is blabbing, 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 and it is blabbing, and this blabbing will be visible. This is under vision, it will be injected, and this is post-operatively at least 8 hours patient will not have any pain. Up to 8 hours there will be no pain. So this is very good in daycare surgery, where you want to discharge the patient same day, because you know bowel doesn't get pain, pain is mostly to the port side. Now complication. In Chandler's study, most common complication is a small bowel injury. We can see here one small bowel is injured, and if it is found like that, immediately you should repair it, and you should not do thorough lavage. You should do locally cleaning by betadine with the sponge, and then continue whatever surgery you were doing. It is not necessary to abandon the surgery. Only one surgery you have to stop, that is hernia surgery, because mesh cannot be applied under infected condition. Various needle injury. Most of the various needle goes unnoticed, but if already you have seen that it has punctured, then one bite should be taken either side and continue whatever surgery you were doing. How you will know? In suction test you will see some fecal matter coming, yellow debris is coming, and then you should try to keep it there and go with the palmers. Remember, don't try to take various needle out, otherwise you can never find the place where it has punctured. This is a rule of any stab injury, that a stab should be kept in place. Then sometime you have retroperitoneal hematoma. This happened because of the trocar has not entered properly, and then you have to cut retroperitoneum, and after that you expose this area, and then you will search for hematoma, and then this is bipolar Robbie dissector, you should coagulate it. Here the one of the mesenteric vessel was bleeding, so it is coagulating it like that. And these are the Chandler's study. Different type of injury has been reported in his study, including iliac vessel, aorta, minor vessel, these all major vessel, all is there. Another injury is trocar site injury. We can see here a spurt of the blood is coming to the liver, and from where it is coming, this is port site injury. If this have port site injury, it happens mostly in the bladed trocar. A lot of ports are disposable, ports are bladed, like I will show you. This is called endopath. This is a very popular disposable port of the Johnson & Johnson, and see here you have to charge it like that. ऐसे charge करना पड़ेगा, and then you will see there is a blade coming. See, there is a very sharp blade. Can you see this blade? बहुत sharp है, and it cuts all the layer of the abdominal wall. This is called endopath. This was a very popular. It is Johnson and Johnson is making, but it is not good because it is so sharp. And if it is good, if you are using one time, do you know why? Because once you will hold it, and then you are going, and if you are using bladed disposable trocar, you should not rotate it like a pyramid. You should go in one go, and as soon as you go, it is discharged. And now second time it will not come. Got it? Now even if I will press, this blade doesn't come out. If I want to press again this knob, I have to charge. It is charged. And now again you go. And if you rotate, it will get discharged in halfway. So you have to go one go. But sometime after one or two use, this blade doesn't follow your resistance. And then it will injure. So that's why I told you that if you are rich, you are using what? Rich people should use disposable, and if you are poor, you should use reusable. If you are reusing the disposable, that means you are very poor. This is not allowed. This is absolutely wrong. This should never be done. So here you can see very poor, they have reused the disposable. This blade has not withdrawn, and it is, so you will go by the hook, and with the heel of the hook you can burn it. It will stop. If that also doesn't work, take a bipolar, burn it. That will stop. If that also doesn't work, use port closure immediately by the suture passer, and due to pressure over the muscle, it will stop. If that also doesn't work, take a Foley's catheter. Put tip of the Foley's catheter inside, distend it, and give a tamponade effect. So pressure se na, and strap somewhere on the thigh, pressure deke, stretch, and then it will stop. Post-operatively, after 2-3 hours, you can remove because it will stop. So trocar site injury. Sometimes bladed trocar directly cut the inferior epigastric. Here bladed trocar is used, and you can see directly it has transected the inferior epigastric vessel. And then severe bleeding has started like this. Now immediately you should remove the trocar, put a finger and give pressure. Trocar nikal ke put the index finger inside and give pressure. And now this becomes your primary surgery. So this is your target. Yes, target change. Target change, and for this target you have to put the port in the another quadrant. You have to put the port to the right side. You will immediately run to the right side. And that's why 2 monitor is always better in the laparoscopy. Now see, this port is coming from right hypochondrium. And then you will try to coagulate. Bipolar is coagulating like this. And so, but from the same side it cannot work. So immediately target change, and then you will do. And then you can use suture passer. Here suture passer is used, and this is taking the port closure needle and passing the suture and tying the knot. Sometimes gas embolism can happen. It is 1 into 10,000 to 1 into 60,000 reported, and it is often lethal. Gas embolism happens because of Veress needle directly going into vein or very high pressure of pneumoperitoneum and extensive dissection. Then this CO2 started entering into vein like a IV fluid. However, thanks to CO2, that even up to 2 liters per minute, air embolism will not happen. But suppose you are using air insufflator, or your pressure is more and gas is entering more than 2 liters per minute, air embolism even in the CO2 can happen. Then pneumomentum. Sometimes a big ball of momentum is distended, like a crystal ball. You will feel like, is it cyst? No, it is not a cyst, it is a pneumomentum. Most of the time it doesn't disturb you, don't do anything to it. It will get absorbed. But if it is disturbing, sitting over your ovary or uterus, go with the aspiration needle and puncture. Then you have surgical emphysema. Surgical emphysema is very common in 50 plus, not 50, 70 plus patient surgical emphysema, very common because their subcutaneous plane is very loose, so gas enters. This is surgical emphysema. Nothing is required. They are doing hernia, even scrotum will swell. Mons pubis in hysterectomy swells. And this is due to the plane going to the, and you will see crepitation. So in those situations, low molecular heparin just given prophylactic 5000 international units subcutaneous, and then it will absorb because CO2 is 200 times more absorbable than oxygen. Pneumomediastinum is a rare condition in which there is a congenital opening in the diaphragm through which CO2 enter into mediastinum. And with each pressure, each movement of diaphragm, it doesn't return back. So this is called pneumomediastinum. How you will know? You have a black shadow, tubular black shadow in the central region. This is pneumomediastinum. You can see this all is pneumomediastinum here. And do you know what it does? It press lung also and press heart also. So your anesthetist will be in trouble. He will say that airway resistance is increasing, tidal volume is decreasing, vital, and even your cardiac output decreasing. These are pneumomediastinum. It's a condition present of the mediastinum. It is not pneumothorax. And why it happened? Because of congenital opening into the diaphragm. So movement of the diaphragm will take this. Every movement of diaphragm will take some gas in the mediastinum and it doesn't return back. Immediate conversion to open surgery is required. If you have a C arm, bring a C arm, take X-ray of chest, you will see tubular black shadow on the mediastinum. Distance between two ports should never be less than 5 centimeter, otherwise it will swell at the level of abdominal wall itself. Mirror image is blunder. Vision axis and action axis should never be opposite to each other, otherwise blunder. You will move right, your instrument will move left. This will be reverse image, mirror image. So this is the summary. Summary is that laparoscopic instrument should always behave like a type 1 lever, always behave like a type 1 lever. Telescope ideally should be kept in between the two working instruments. Manipulation angle ideally should be 60 degree for contralateral and 30 degree for ipsilateral. Distance between telescope and instrument should never be less than 5 centimeter. And azimuth angle should vary from 15 to 45, ideal 30. And shadow of the telescope should be down, so light cable should be up. Remember, light cable always should be up. Light cable always up. So shadow will be down. Do you know, old telescope there was no shadow. Older telescope there were no shadow, because old telescope, if you will see how it was made of, old telescope they have made different way. So this is the telescope. Lens was in the center and the fiber optics were on the side to put light. But there was one problem with this telescope, that there was no shadow. Because light was going on the same axis, image is returning in the same axis. So shadow was there, but it was just behind the object. So telescope cannot see, and people were happy that no shadow. But later it was realized that shadow is important in laparoscopy, because shadow gives you depth perception. Like shadow of my nose is here, shadow of my specs are here. Can you see that? Shadow of my this lip is here, shadow of my coat is here. Shadow gives you this shadow here. Can you see the shadow? You don't have to see shadow, your brain knows that. Because from childhood you learn the shadow and you know the curvature by shadow. You can draw 3D by shadow. Shadow is also a depth perception by depth cube, shadow. But shadow is only possible if light is going from some another axis and returning from some another axis. So this was same axis. So now new telescopes are like that. That light is on the top. Here से light यहाँ रहता है and lens is here. So they give shadow. And shadow is very important in laparoscopy. See, these all are shadow telescopes. जितना भी telescope देख रहे हैं ना, सब में shadow है. And now shadow telescope. So light is coming from the top and then returning in the other axis. Just like, have you seen any camera where flash is on the bottom? Why flash they keep on the top? Because sun is above. Because sun is above, that's why light should come from the top. That's why in the house we keep light on the top. We never feel illuminated from below except in disco or DJ. In disco they keep light on the floor. So telescope 30 degree layer. Light on the top wala and एक mobile phone. So always light on the top. So light cable top. We are never, if light cable you will put down, shadow of this will go up. Shadow of this aspect will go on the forehead. And then our brain confused. That's why in disco they put light on the floor so that all is confused. Nobody can say who is beautiful, who is not beautiful. All is good. All will dance. Everybody dance. That's why dance on the light on the floor. So this is always keep light cable up, even in 0 degree. If you will keep light cable down, shadow of gallbladder will fall over abdominal wall and your surgery will be bad because shadow will be up. So this is very important. I have a privilege that with my professor, this shadow casting illumination was my research. Shadow casting illumination in laparoscopy. Before this, Storch was making light all around, fiber optic all around, but this shadow casting illumination technique was my invention, although I did it in 1998 itself, but it was, published in American journal. This is my complete name is this, optimum shadow casting illumination. And then this research Storch has taken, and after that they have started making it this shadow telescope. So now they have put the light cable down. So this is very good that you should take care that shadow should be down and the light cable by default always keep up. Otherwise if you will do, it will be in 30 degree anyway it should be down, up, so shadow down. But even 0 degree, some people, because it is touching the hand of the surgeon, so they say that keep the light cable down, don't do that. Otherwise your shadow will be wrong. So this is a summary of the baseball diamond concept. So is there any question? So I will just demonstrate you. This is the telescope and see here is a light support, and see if I am putting this light, and see here light is on the top. If you will see very carefully, the lens is on the bottom. Did you see that? Light ऊपर है, lens नीचे है. Because sun is above, so light on the telescope is above. हमेशा ऊपर रहता है, नीचे नहीं रहता है. And then only it is never all around, always on the top, little on the side like that, like a moon, half moon. And on the bottom lens is only there. All the telescopes has been changed. This is your last day event. That will be your graduation day, and that will be on 14th. This is Dr. Sudhir Srivastava. He is my very good friend and he is the owner of the Mantra robot. And we are the research partner of the Mantra robot, where we did first animal trial and then first human surgery also. And in this convocation he has come.
It is it's really admirable that the group that's sitting here, and congratulations, you're all graduating today from this learning experience this time, and it shows that you want to do things differently. So what I will say in a few minutes is that one should never become comfortable. One should be contented with life but never contented with our progress. And I always say that best is enemy of better, because every time we think that this is it, no, this is never it. The status quo is the worst thing that one can kind of fall into, because today I think we see the progress is so fast and so rapidly that is happening literally globally in the field of science, in the field of technology. And when we talk of medicine, if you really think about, the world population is growing, the disease spectrum is growing and changing, and how can we really help people? And the best way is utilizing the technology, the new innovations, new ways. So with that, I want to congratulate you again and keep the journey going. Don't give up and keep pushing for better and better. Thank you.
First of all, I would like to thank you, Dr. Mishra, Dr. Bala, for your enthusiastic learning.
I've learned that
Sad part.
Dr. Mishra I lot like PGI, the basics of how after attending sir's classes, now I know